Hi, everyone. I hope you can hear me okay. Oh, I'm echoing over. 1 second. You would think after 2 years, we'd have this down a little better. First, I know I look a little funny with the headset. I have found with Zoom, for some reason, if I speak through my laptop microphone, it makes me sound very robotic. So I hope this is kind of a good workaround. And please let me know in the chat if I sound funny or if you can't hear me well, and just have a little patience with me. I don't think you're going to have the same issue with any of the other speakers. It's just on my hardware. So I'm Jillian Farrell, Development Director with the Washington, Alaska chapter, and we're just so excited to have all of you joining us here today. First, I want to say a big thank you to our panelists and our presenters here for sharing their expertise. I know we have a lot more people that are going to be joining us, but I just really want to get us started because I want to keep us on schedule today. So I'm just going to do a quick housekeeping before we kick it off. First, at the bottom of your screen, you're going to notice a few icons. The two we'll be using is the chat icon and the Q&A icon. So during it, you're welcome to chat with the other people you see on. But if you have a question that's directly to one of our presenters or our speakers, please put that into the Q&A box. And that's what I'm going to be moderating. And so when they're finished, if there are any questions, I'll make sure to relay those back and forth. I think that's pretty simple. So that's it. We'll get started. First off, we have Cole Brewer. He's a young man with CF. He's a really integral part of our community, and he's going to share a bit about his journey. So we're just so excited to have him. Thanks so much for being here, Cole.
Thank you, Jillian. So hi, my name is Cole Brewer. I am a senior at Hazen High School. I'm 18 and I have CF. Start off, I just want to make sure you see the slides that I have up, the PowerPoint. I think it should be good, but
Yes, we see. It looks great.
awesome. Thank you. So like I said, I have CF. When I was born, my parents, the life expectancy for someone with CF when I was born was mid to late 20s. And that's from talking with my parents, that's a scary thought to have. Definitely something that makes you question, having more kids with a chance of them also having the same disease and things like that. But now the life expectancy is 40 plus years, and it's only been growing as I've gotten older. So it's something that we've prayed about, and something that's always been just on our minds. And we've done so much work with the CF Foundation, and so many people have helped that we've gotten that life expectancy up, and it's gone further and further, and it'll just keep growing, and we're really really happy about that. My life with CF has been fairly well. I wouldn't say easy, but it's been compared to some other people with CF. I haven't struggled the same. I haven't had the same struggles. I have had mostly like gut and issues, along with some lung issues, but I've never been hospitalized for lung issues. I've been hospitalized for other CF related things that can be difficult, but I've been lucky to not have anything really, really terribly wrong with my lungs. And when I was little, we would be, for my enzymes, we'd put them in like applesauce and things. And I remember one of the first times we were out at lunch somewhere, and I was talking with my mom. There was like a toy I wanted at a store, and she said if I could take my enzymes in the whole pill instead of opening them and pouring them in my applesauce or like my water or something, that I could do that. And I remember trying to build up the confidence, and then I didn't do it. I didn't do it because it's scary taking all these pills, and now I take I can take 10 plus at a time, but that's definitely something that was one of the big things that I would be in front of my friends taking pills, and they have questions for me like what are those, and I didn't know anything different. So for me, when I was younger, CF didn't seem like something that was different from everybody else, because I most of the stuff that I did to take care of myself with my CF was at my house. Besides taking pills for like meals and things, it wasn't really presented or public to anybody. And so I thought that everyone else's lives were the same at home, right? And so I would fight. I had like Pseudomonas I would fight with here and there. I would take antibiotics for. I went through a lot of like sinus infections. Lots of hours and hours wearing my vest and doing my inhaled treatments. And that was kind of just on and off. I would have to sleep upright in my bed at night because I'd have bad coughs and things like that. And I remember a couple of years back when Trikafta was coming out, and I wasn't eligible for the drug. Before that, I can't remember the name right now, but and I remember just being so hopeful and waiting for the new drug to come out. And I remember being at my grandma's house when my mom had a notification on her phone or a news article or something that was pulled up that Trikafta had been approved. And I remember it being such a, I think, emotional. Like it was very like, wow, it's happening, right? What, like our prayers and all the work we've been putting in and the time we've been putting into the CF Foundation and everyone that's been helping has just made such an impact. Like I will have a medication approved for me to take and approved for a lot more of the population of people with CF to take. And I remember just within the first month or two of taking Trikafta, I was released, like getting more like mucus out of my lungs, and I was feeling like I could breathe better, and it was going really good, and it still is. It's going amazing, and I think it's hard for me to be doing my inhaled treatments still because of how much Trikafta has done for me and how much it's changed the way my everyday life kind of is, and how much better it's made. My lung function percent has gone up like 10+% in the past couple of years, and it's been a huge blessing. I think also kind of like what I was talking about earlier with the social aspect with people, having it's having one of the main things that I have to worry about with my CF being not being able to go into hot tubs with my friends is I'm pretty lucky. I'm pretty blessed for that to be the big thing that I have to worry about. And when high school came around, I wasn't on Trikafta yet. That was maybe like halfway through high school, maybe a little before. And so there were things I wasn't sure about, like sports, being able to perform and not have to be held back by my CF. I definitely have had some episodes with that still, but not nearly as bad. And it's been a really it's just been really hopeful that I've been able to do all the things and not have to worry about the things that I did have to worry about before Trikafta. And so these are just a couple pictures of me when I was younger with my treatments and things at the hospital. And then there was one, and this is me very excited to do all my meds. And like I said, now I don't have to worry about, sports and doing what I want to be able to do, spending my free time where I want to, instead of having to sit at home doing treatments like, playing guitar and doing photography and creative things around with friends and things that I had to worry about a little bit more beforehand. And also when the another kind of social aspect, I don't really necessarily share a lot with my friends about it. Close friends definitely know, but I don't go around, kind of using that as my identity, because I want people to see me for not what CF is, and not what it can do to me, but how I can overcome it. And so the movie 5 Feet Apart came out, and that's when a lot of people started, like, maybe they'd heard something about, oh, Cole has CF, is this what it's like for him? And it was kind of like a realization for me, like after I'd seen the movie, like there are a lot of people with CF that struggle a lot more than me, and I want to do more to be able to help those people and advocate for them, because I'm so fortunate to be in a situation where I'm not as unhealthy. Especially finding out about CF so early on, when some people don't find out so early on, I've been able to stay on top of my meds and stay healthy. So it's really awesome. And we're just so excited that I'll be able to go out of state for college and be able to move and live on my own and not have to worry about needing to stay close and things. And, of course I'll have my care down there and staying on top of my treatments as much like when I need to there and everything. But it's just been really encouraging that I've had so many opportunities with CF, and how much progress has been made in that area. So just in closing, I think I want to leave you with, there will be hard stuff. There will be challenges that will come with health, with social things, with anything, and it doesn't stop. But the biggest thing is to be optimistic about it, because you can't control those things, but you can control, how you deal with them. And I've, with my parents going through this, and how they've been supportive, and just being optimistic and supportive is the best way to go, no matter what happens. That's kind of, that's the most important thing. So thank you.
Thanks, Cole. If anyone has questions for him, you can pop it into the Q&A. I do see one for you, Cole. Was there ever a time that maybe you were less compliant or fought kind of like the treatments or taking the meds? And, I guess if you could chat a little about that, or like what kind of, if that was the case, getting over that.
Yeah. I think I think when I was younger, there was a bit less of that. I definitely kind of just accepted everything that came my way. I didn't really, like I said, know anything different. There definitely were times though with school where I wouldn't want to take up time. I wanted to do other things, and especially feeling like I didn't need it was maybe part of the issue, right? I think like more recently though with Trikafta, it's been doing such a great job that it's hard for me to want to do my treatments. And when I get sick and things, I am more motivated to keep myself healthy. But it's definitely a struggle when I'm feeling so great. And Trikafta's done such a great job with my helping me with my health that, yeah, it's definitely difficult. And I think just trying to remember that I like remember what CF is, right? And keep reminding myself of that and saying like, well, I really want to be healthy long term and things. That's really the biggest thing. And almost kind of supporting myself in that, like, well, you know, you want to be healthy long term, and so you should really work on it now is kind of my biggest fix for that.
Amazing. You and your family are so dear to us. So thank you so much for coming on. I know Saturday mornings aren't the most convenient. And so presenting, a lot of folks that are on this, I think this event is usually most popular to those that have young kids with CF. And so getting to really hear from you, that's just a few years older, going to college out of state, like really nothing slowing you down. I think it lends a lot of hope and it's very exciting. So thank you so much for being here.
Yeah, thank you for having me.
Yeah. All right. Next up, we're going to go to Dr. Liu, and she's going to be presenting on youth mental health. Dr. Frida Liu is a pediatric psychologist embedded with Seattle Children's Hospital CF Center. She's also the director of measurement-based patient care for outpatient psychiatry and an assistant professor of psychiatry at the University of Washington School of Medicine. Dr. Liu's program of research aims to develop scalable mental health service interventions to improve access and quality of mental health care for diverse youths and families. Specifically, her work is focused on the implementation of measured-based care in diverse youth mental health care settings, the development of implicit bias interventions for healthcare providers, and the co-design and evaluation of telehealth therapy groups for teens with cystic fibrosis. Thank you so much for joining us today, Dr. Liu.
Okay, let's see if the technology will cooperate here. Can you hear me?
Yes, we can hear you great.
All right, fabulous. I'm going to try sharing my screen. And let's see if I can still see. Oh, I guess I'm used to providing trainings where I can see folks. So I was like, well, actually, I guess there's no one to look at.
No, it's just us. No, it looks great. We see it.
Okay, fabulous. All right. So I am going to talk about mental health and wellness during the pandemic for our young people, for our kids and adolescents, and specifically in thinking about, you know, how CF has impacted all of us. And let's see, getting a little technology bits. Bear with me for a second here. Having window issues where I can't see my slides. Okay. All right. So let's move forward. So I actually prepared a fairly general talk. So, you know, some of this will obviously be familiar to some of us, but hopefully there will be some new information. So my disclosures, I do receive research funding from the Cystic Fibrosis Foundation, and I'll actually talk with you a little bit about the work that we're doing with that funding. And in the time that I have today, I hope we'll have time for some Q&A. But for my prepared remarks, we're going to, you know, broadly talk about the impact of the COVID-19 pandemic on youth mental health just across the board, and then share some typical reactions that people have been having. And then think about how do we promote mental health wellness during this time? And that, you know, when we think about this time, when we started this conversation 2 years ago, I think we were thinking about, you know, how do these next few months is going to impact people, but we've really come to understand that this is a long haul. Right, that we've been in this for a couple of years now, and now we're all sort of shifting to how to figure out how to live with this as part of our new normal. And then, of course, we're going to talk about when to seek help and where to go. Okay, so you know, by far the most significant thing that has happened to all of our kids is school closures. That in terms of the most disruptive aspect of the pandemic. And that with school closures come with social isolation, especially from peers. And as kids age, you know, we think of our little ones as very attached to our families, but as they enter school and continue on to adolescence, peer interactions become more and more important to their overall development. And then we think about the struggle with online schooling, and though recognizing that some kids have really thrived in the online schooling environment, that the impact of online schooling has been quite uneven across the board for our youth. And so some kids are obviously falling behind. And we do know that sort of nationally, internationally, from the research data, that as a whole, most kids have fallen behind by some degree in terms of their education. And then, of course, after all the various lockdowns that we've experienced, transition back to in-person schooling has also been stressful for many youth. And you can imagine that, as we've had to quickly adjust to stay-at-home orders and staying very close to our families and not being able to get out, suddenly having to reinitiate those skills required for interacting with the broader world again can be very difficult for some youth. And I'm sure for all of us, for adults, many of us have had struggles returning back to our normal routines or going back to work in person. And then, of course, the increased screen time that's just been required, whether it's that parents are working from home and we don't have childcare. And so then we have to allow our kids to have more screen time just so we can, get on a meeting or get a little more work done, or just that there are fewer opportunities and activities that we're able to engage with that we used to be able to do prior to all of our concerns about the spread of COVID-19. And so that has led to significant increases in screen time for not just youth, but for all of us, right? But we can understand and imagine the developmental impacts of having too much screen time on kids. And of course, children, young people, everybody up to, about the age of 18 before go off to college or going on to their own exists within families. And so when there are family stressors, kids and adolescents are certainly affected. And so we have seen during the pandemic increasing rates of parent-child conflict. So, when you're with each other all the time, sometimes that's going to just lead to conflict in and of itself. If prior to the pandemic and prior to these situations, we've had, pre-existing conflict, you can imagine how that may worsen. And then, of course, the change in routines, the lack of access to our usual resources, even just thinking about, other folks who might take on childcare duties that'll, act as a let-off valve, right? So that if you're having some conflict with your kid, that they get to go somewhere else. And school used to serve that purpose. Prior to the closure of the schools and everyone going to online schooling. So again, shifting in all of those routines, even going back to school, can be stressful just in all the change that has demanded of us. And then, of course, parental stress, even if it's within the parental unit, between parents or just parents experiencing all their own stress, can bleed over to young people that it affects their wellness. And then, of course, loss and bereavement. Of all the things that we've lost during the pandemic, many have lost time with their friends, have lost developmental opportunities, have missed major significant milestones like graduation or prom or, some of those really important things that young people look forward to. And of course, many of us have had family members or ourselves been affected by COVID, and there's actual loss of family members, right? People have been experiencing illness and death. And so those are huge impacts on youth and all of us. And of course, just the daily stresses of coping with all of the COVID precautions and the ever-changing COVID precautions and keeping up with all the CDC recommendations, and then coping with fear of illness and illness itself. And just thinking about, even the added stress of just having a cold and not knowing if it's COVID, all of that is part of these stressors that everybody has been experiencing. And then you add CF on top of that. And what I've noticed, and what some of my colleagues have noticed, is that at the beginning of the pandemic, I felt like, the CF community was actually more ready to face this kind of restriction than others, because it was sort of like, well, this is our everyday life, right? But as the pandemic continued, we really began to see the toll that it took on our families with CF and families coping with other chronic illness, is that you're having to be that much more vigilant or that much more concerned. And even when the world started opening up and the risk factors decreased for folks who do not have pre-existing conditions, for those with, especially those with lower lung functioning or with more illness, it feels extremely or especially unfair that when the world is opening up again and other people have moved on, it can feel like those who are struggling with cystic fibrosis or other conditions are left behind, right? That the public health precautions did not have in mind everyone who have special conditions. The silver lining that we've seen in the CF community is that those with intact lung functioning are sort of responding to COVID even when infected, much like the rest of the population. And that's sort of the bright side, but really recognizing the added burden that it has been, and especially for our families with young children. And I feel like even with or without CF, for families with young children 5 and under, or those below 5 who have not had access to vaccines, the news and the media and public health measures, the way that people talk about it, people are often forgetting that those of us with little ones are still not able to live normal lives because we still have vulnerable folks at home, right? And you can imagine in those early years, as families are still adjusting to the routine of CF and having a toddler that you feel like you really can't let out of the house while you're just being driven mad by having to be with the toddler among other children for 24/7, and how stressful that can be for families in general. And so in the context of all of that stress that everyone is experiencing, especially given the added burden of CF and CF care, we can expect a range of reactions. And this is what I would consider, within this range, this is what I would consider typical reactions to acute stress. And this, you may have experienced these yourselves within your own family, especially at the beginning of the pandemic. So, it's common to have a sense of confusion or uncertainty, or just a sense of disbelief, like this can't be happening, or experiencing intense worries, or feeling like you can't stop worrying and the mind is sort of jumping from one thing to another. And just kind of this general sense of being on edge or irritability. And you could see this in your children. You might have experienced it in yourself early on. Many people reported disruptions in sleep, daily routine, and then just kind of decreased motivation, even though feeling like, well, I'm not commuting, maybe I'm working home, I should have extra time, but I don't feel like doing anything, right? Many people talked about giving up exercise during the pandemic, though I know there are groups of people who have really gotten into exercise. And then, of course, the overwhelming isolation and loneliness, especially during the early lockdown days. And as I mentioned before, grief and bereavement, and even just grieving the loss of our daily routine, can be heavy and take a toll on us. And I did put in here, even though mostly I'm talking about sort of immediate short-term reactions, grief and bereavement can last a long time, and it can still be normal. That many people talk about, that first year of experiencing a major loss, to really just not be able to feel like themselves or do much of any of their normal things until about a year later. And then developmentally, we may see different kinds of initial reactions that are fairly typical. So in the little ones, for toddlers and our preschoolers, we might get some questions. You might see clinginess, definitely some irritability can happen. And then lots of sort of playing out COVID scenarios. They may be talking about, their dollies getting sick and their friends being sick and folks needing swabs. And that's all normal. This is how young little ones really cope with change. And that's perfectly appropriate for them to be doing that. You might also see no reaction at all, like no notable reaction at all. And that is okay. That is not abnormal. Some of our little ones have actually spent most of their life, most of their memoried life, the part that they can remember, during the pandemic. And this is their normal, for better or worse, right? And some believe that our little ones are actually more protected psychologically from the stressors that has come along with the pandemic. Now, for our school-age children, we definitely expect to see lots of questions, worries, reassurance seeking. You're likely to see some irritability and low mood at times. And then for our teenagers, it's again normal, developmentally appropriate for them to underestimate personal risk. With or without the pandemic, teenagers tend to believe that they are invincible, right? And in some ways that makes sense developmentally, that at that age, when they're separating from the family and starting to think about themselves as individuals and going on to explore the bigger world, you need a sense of that invincibility to really be able to get out there and sort of try yourself out and figure out who you are, right? During the pandemic, there's some extra risk associated with that, and teens often underestimate that risk. You may see poor decision-making, especially when they're with peers. So maybe they're really good about keeping their mask on when they're with family and outings, at the supermarket, doing their normal things, but you throw them in with their friends and you take the adults out of the equation, suddenly everybody is without masks. And again, that is normal. That is typical adolescent behavior. And so the question is, how do we keep our kids safe within all of these typical behaviors? And I emphasize here that this is sort of initial short-term reactions. If these experiences or these behaviors or symptoms or changes in mood and irritability in your young people persist, that's when we may begin to think that it might be time to consider getting some help or consider doing something different to sort of shift things up. And it's hard to judge how long things have been going on, especially given sort of like the pandemic. I feel like we all have a harder time just imagining, how much time has passed by. A colleague of mine liked to say time is an endless flat circle, and that's how they're experiencing time during the pandemic. And that especially with the ups and downs of the different waves and the different variants and the different concerns that we've had, each time a new sort of thing comes up with COVID or a new sense of urgency or a new thing to be worried about, we can see a resurgence of some of these reactions, and that could still be within the normal range. My general rule of thumb for where the cutoff is for this is not working for us, this is not, this is not typical anymore, we really should be thinking about doing something different or getting some help, is if the reactions that you're seeing are prolonged, even during times when things are sort of calmer, and or it's really getting in the way of daily living. It's really getting in the way of folks, kids getting to go to school or focus on school, being able to enjoy time or just be with a family, being able to connect with friends, sort of thinking about all of those typical things that kids ought to be engaging in at that age. If it's really getting in the way of all of that, then is when we should think about connecting with some professional help. And we'll talk about some signs and symptoms for that in a little bit. But first I want to address, how do we prevent ourselves from getting to that stage, right? We're all in this state of stress. How do we sort of promote wellness and stay as healthy as possible? And the trick of it is really about staying active. And I mean in every which way possible. So physically, mentally, socially, continuing to stay engaged with the world. And that's a big ask. That's a tall order when so many of us are, especially now, used to the routine of social distancing and sort of keeping isolation protocols. Sticking to a routine can be really helpful, especially at the beginning of the pandemic when things were really disrupted. For folks who were able to develop a routine and really get back on, even if it's not the same routine they had before, tended to do better than folks who were not able to establish routine. And I know some of you may be rolling your eyes at me and going, well, my teenager is still hanging out at home because they haven't gone back to in-person schooling, and online schooling can happen whenever. So they're waking up at noon and there's absolutely no routine. And that is the reality. I fully admit that that is part of what a lot of folks are living with. And any amount of routine we can interject, even if they're getting up at noon, if it means that they're getting up at noon and then they get something to eat and then they take their medications and then they do their treatments, that's part of a routine, right? Any kind of normalcy that we can generate is better than none. And so, the reminder, don't forget to work your treatment activities into your routine as much as you can, right? Go outside. Leave the house, do get out, even when we have new variants cropping up, even when it's scary, we take all the precautions, you mask up, you gel, you do all the things, you stay out of indoor unmasked activities, but we try to, leave the house, even if it's just to walk around the house, walk around the block. But if all you can do is get into the yard or just stand on the porch, make whatever little step possible. Limit screen time and media exposure. So one thing is the total amount of time that we're all spending on screens. The other thing is that we find that for youth, and I'm thinking it's the same for adults, but youth can be more sensitized to this, that the more media exposure, like to news that folks have had, to coronavirus news, basically, we see that kids are at higher risk for developing symptoms of anxiety and depression if they're having excessive amounts of media exposure. And then sleep, preferably at nighttime. Again, I understand that our teens and young people sometimes have their day-night all turned around, but preferably we're sleeping at nighttime and keeping a regular wake-up time and bedtime as much as possible. If you're finding that you're sleeping, sort of at regular hours during the school days, but then, or that your young person is doing that, and that on the weekend they're sleeping in a lot, that means they're not getting enough sleep during the week because their body is doing catch up on the weekend. And that's okay if the schedule is set up that like that's the only way they can do it. But that's just a cue that, okay, we're having some sleep deprivation going on during the week. And then connect with friends and family as best as you can, even with all the precautions in place, right? Stay safe, but don't give up on being able to connect with them. If the best you can do is connect by, video chat, then do that. But if you can see them outside, see them outside. So again, it's about making steps and towards connecting with people that we care about. We're social creatures. We do much better, all of us, when we are surrounded by others. Especially others that we care about and we have a sense that they care about us. And accept what you cannot change. Now, acceptance is tricky. Sometimes people struggle with wanting to expect because it means that you somehow have to not do something about the situation. And that's not necessarily what it means. Here, acceptance just means I recognize that this is my current reality. I recognize that there is a contagious respiratory disease going around, and that means some precautions has to be taken. I don't have to like it, right? And that's the piece of acceptance, where I recognize that right now, my school still has masking requirements in place, or that I recognize that my school's masking requirements are gonna go away and that my friends are okay with that, but I'm not, and that I still have to keep my mask on to stay safe, and I don't like that. And noticing that you don't like that is part of the acceptance, right? Acceptance does not mean you have to like it. It also doesn't mean that you can't do something to try to change it. You can try to create environments in which it's safer for you to take your mask off, right? You can develop a friend group that may support you and maybe will mask in solidarity. So just a couple of examples, not suggesting that any of those things are particularly easy. And then finally, do what you love as much as you can safely, even if you don't feel like it. So this is the tricky part. Sometimes when we get into a funk and we get into low mood and having low motivation and sort of feeling like, I just want to, sort of a bump on the log. I don't feel like doing anything. I just want to be a couch potato. The more that we sort of stay there, the more that we want to stay there, the more that it's harder to work up the motivation to go do something else. The biggest thing is putting on your shoes and putting on your coat and getting outside. And sometimes just stepping outside will help the following steps of, if you had a plan to say, walk around the block, right? Or to go walk your dog. Get back to doing what you love, even if you don't feel like it in the moment. And if you can't do the thing that you love, let's say, I don't think this is a popular activity for most young people, but let's say what you love to do is bowling. And you're like, I really shouldn't be indoors with all the bowlers now that their, masks are off and all of those things. Is there a way for you to still do that safely? And if not, can you think about what is it you love about that activity and explore other activities that might give you that same thrill? And it may mean exploring some new things that you're not used to doing. And it may mean that in the beginning, that thing is not as fun as the other thing that you're used to doing, but there could be fun to be had as you continue to engage, right? The more you do, sometimes the more that we get to enjoy it. And then throw yourself in. When you're doing the thing, be all about it. Don't be there and then grumble about how I'd rather be in my pajamas and in bed, because then you're missing out on the experience that you could be having. And then you really are not noticing whether you're able to have fun and enjoy the activity. So then you would have gone through the trouble of doing it and still not gotten the benefit from it. And then finally, ask for help when help is needed. We are, again, social creatures. We're not meant to do this on our own. And that's one of the hardest parts about the pandemic, is that it has been really isolating for all of us, especially at different times, right? And so it is absolutely okay and appropriate to ask for help. And sometimes asking for help lets other people know that they're not alone, that you're sort of modeling and demonstrating. And this is an important piece for parents of young people, that if you can show your young person that you're out there asking for help when you need it from trusted others, they'll have a good model for how to do that. Okay, so when to seek professional help. I'm going to highlight some things that have been especially salient during the pandemic. There are lots of things that one should and could seek help for in terms of mental health care for young people, but I'm going to try to focus on the things that have come up the most frequently during the pandemic. And so depression, is exemplified by prolonged periods of low mood. So we're thinking like a couple of weeks at a time, not a lot of motivation, really lacking a sense of enjoyment, even in the things that they used to be interested in. You might also see poor appetite, sleep disruptions, and then sort of talk or just other evidence of thoughts of death or dying. Now, I know that some of the physical symptoms may be hard to distinguish from depression versus physical illness, because I know some of our, kids with CF can often present with poor appetite or difficulty sleeping if they're starting to go into an exacerbation or starting to get a respiratory illness. So again, we're looking for kind of longer periods of these patterns. And if it's disrupting normal daily functioning routines, like they're not able to get out of bed to go to school, they don't want to see their cousin, even though they usually really love having that interaction, they're turning down opportunity that they would usually typically enjoy. And also in younger kids, we could see a lot of irritability and tearfulness. It can also present in that way. Or a sense of withdrawn, like just kind of turning in on themselves and not connecting with the family. The other piece that's come up a lot is anxiety. Now, for kids who've struggled with those social anxiety even before the pandemic has been really difficult because of the getting out of school and getting back into school. And for these kids, going back into school, and for adults, for a matter of fact, struggling with social anxiety, going back to work can be just insurmountably difficult. So you may see school avoidance, or this inability to really go back in person. And a piece that's related to this that I didn't call out here is that we are seeing increases in disordered eating behaviors that during the pandemic, with the disruption in routines, and also just with development, it's been 2 years, right? And some kids have been out of school for more than a year. Kids have experienced lots of changes to their body, whether it's weight gain or just maturation from the normal processes related to growth and puberty. And that could lead to discomforts or fears about going back to school and having their friends see them differently. And for teens, we're starting to see, more disordered eating behaviors, sort of body checking or sort of trying to cover up in extremely baggy clothing, not wanting to be seen. And sometimes that can lead to school avoidance of folks not wanting to return to in-person schooling. And, we also had kids who are used to wearing masks, not wanting to remove their mask, not because of concerns for contamination or infection, but really concerns of sort of their whole face being seen, especially if they're in a time of their life where they're developing acne. And you can imagine how we have maskne as a thing that could sort of be a self-propelling cycle. And then obsessive compulsive disorder is another thing that we could see kind of pop up more severely during the pandemic, especially as folks are really concerned about contamination and infection protocols. So the question is, what's the line, right? Where do you draw the line between typical protective behaviors of keeping things clean and not wanting to reduce infection risk for infection, and when it becomes excessive? Again, this is where we think about how disruptive are the activities to their daily routine, and how much extra is someone doing above and beyond, say, CDC recommendations for cleanliness or for decontamination of their areas or surfaces. Sometimes OCD can show up as irritability and kind of bossiness around what family members do, not only what they do themselves. So if someone is overly concerned about germs and contamination, you might see the typical hand washing stuff, but you might also not. You might get a kiddo who is telling the parent, you can't enter my room because you haven't changed your clothes, or you've been, to a gathering and so you can't come home and I don't want any hugs. And it could get fairly excessive in that way. And during the pandemic, this is really hard to distinguish because we are all doing more. And for families who are living with CF, some additional precautions is appropriate, right? Especially depending on the conversations you've had with your own pulmonologist or your own provider. Okay, and then another piece is traumatic stress. So that during COVID, like I talked about, many kids and families are experiencing traumatic losses, whether that's the illness or death of a family member or traumatic engagements with the medical system. Now, many of our families with CF have had their own experiences of traumatic experiences with the medical system prior to the pandemic, and that sometimes the pandemic can provide more opportunities to exacerbate some of those historical traumas. And so you may see intrusive re-experiencing of a situation or excessive efforts to avoid reminders of the situation. Again, if these symptoms are getting in the way of daily living, if a young person is having so many nightmares that they're afraid to go to sleep and very little sleep, and that's tanking their mood and making them feel hopeless, that's definitely a time to seek help. So let's see, and just as a kind of a broader picture here, we know from the emerging research that is coming out that globally across the world, young people, especially adolescents during the pandemic, have shown greater risk and worsening rates of depression, anxiety, and substance use. And that the situation is slightly worse for girls and definitely worse for transgender and gender nonconforming youth. So those are just kind of the bigger picture to keep in mind. And then of course, in addition to all these areas that I said, can be especially salient during the pandemic that we've seen more of, there's also all the things that kids are typically struggling with, like keeping up with their academics, and you might have a youngster who is struggling with attentional difficulties, you may be having family conflict or other risky behaviors. And all of those things are deserving of attention and help if it's disruptive of daily functioning, whether at home or at school or in other important contexts. Okay, so where to seek help? One of the first places you can go to is your CF team. Most CF teams have a social worker and or a mental health coordinator. Sometimes that's the same person. Some teams have a psychologist, like at Seattle Children's, like myself. And so if you're receiving your care at Seattle Children's, you can ask your pulmonologist or social worker to facilitate a referral to see me. I have a small team, so I do have a trainee with me most of the time. So that allows me to expand the service and double our capacity to see more people. And we do evaluations, consultation, brief treatment, as well as follow-up and referral. Because I am an embedded member of the CF team, I'm around, so we can do a period of an episode of treatment, have things kind of shape up, and let the kid and family go on their daily routine, and sort of for us to step back. And then because we're with the team, we're always going to be here. So at other transition points, say transition to middle school or high school, we can check in again, or changes in the family that might require more support. I am also a member of the psychiatry team at Seattle Children's, and outpatient psychiatry offers a wide range of services. There is a wait time, but we can get folks referred for any kind of just about anything, but primarily, anxiety, ADHD, depression, all of those typical things, we can provide services. And typically at outpatient psychiatry, we try to start folks in a group program to serve as many people as we can. And then if more is needed, we'll transition folks to brief individual interventions. And there's also medication management as another layer of support. And then of course, your primary care provider may have their own referral network. So that's always a good place to start. And then schools also have mental health resources. Not every school will have mental health resources, but some schools in certain school districts have mental health providers who are either on staff or they have an embedded healthcare clinic that provides, in King County, this is the case. Many of the schools, many of the high schools, especially, and middle schools and elementary schools have these services. They may not have a clinic room, but they have primary care, dental, and mental health. And in the state of Washington, for kids who are 13 and older, you can access mental health care confidentially. Ideally, parents are involved and you sign consent, but a 13-year-old can sign their own consent for care. And so confidential services in schools is another way. Now, if your adolescent or your school-age children is having academic difficulties, that first line of outreach should definitely be the school team, because the school is responsible for providing services that will allow kids to access a free and fair education in the public school system. And then we have this additional resource that's called the Washington Mental Health Referral Service for youth up to age 17. Once you turn 18, you have access to adult services. So this referral service is primarily for folks who are 17 and under. And there's a provider link as well, but this is the family link. And so if you go to this website, you'll get additional information on how to access the service. And basically, you put your name in, and then someone will work with you to look at your insurance and look at what your child needs, and to try to identify providers for you to be able to reach out to. The service is well used. And so I hear that it's about a couple of week wait to actually get that contact when someone is talking with you about the specific services, or to get a list back and to get additional support to accessing those providers. And then sometimes there are mental health research opportunities. So this is going to be a shameless plug, but I do want to share this opportunity with folks that at Seattle Children's, we're currently running a telehealth group therapy research study, recognizing, and I actually started the study before the pandemic, recognizing that our young people with CF with modern isolation protocol, never able to be together in the same space. And with the advent of telehealth, I thought that would be a great opportunity to bring kids together. So this study is for teens 13 to 18 years of age who are still in school, so middle and high school, who have experienced some symptoms of depression or anxiety, and who lives in Washington, Oregon, and we may be able to accommodate folks who live in Idaho. So do reach out to us to talk about that. Participants will get free diagnostic evaluation, as well as 12 sessions of group therapy. And then there's some follow-up. There's a follow-up period where we ask you to complete some measures. There's no pokes, there's no blood draw, there's none of that. You can participate entirely remotely by telehealth. There's no travel required. And we just asked you to show up to group and then complete the weekly questionnaires. And the teens can get paid up to $300 for participating. And it is my study, so that was part of my disclosures. And if you're interested, please reach out to us at the cfresearch@seattlechildrens.org email address and reference TACTIC, which is the acronym for the study. Okay, and I will stop there to see if we have any questions. Oh, I'm recognizing that I've ran over on time. I apologize.
Oh, yeah, no worries. I don't see any questions. I'll give a second just if any pop up. But I do want to say, of all the topics, mental health is what's always requested, and very specifically youth mental health. So it was such a joy to have you, and so needed. And so thank you so much for joining us today.
Oh, thank you for having me. It's delightful to be here.
All right. Well, I know I'll let you get back to your day. Thank you for joining us. We'll move on to Trisha Burch. Trisha is going to be speaking on child life and coping plans. Trisha Burch is a certified child life specialist, recently added to the cystic fibrosis team with almost 10 years of experience at Seattle Children's Hospital. Child life specialists focus on the emotional and developmental need of infants, children, and teens in the healthcare setting. She's available to meet with patients and families to help patients understand CF, develop coping strategies for blood draws, throat swabs, and other medical procedures, in addition to assist with home therapy compliance and offer support for siblings. I'm just going to jump in. That's something actually we were just talking about, is that I think is ignored a lot, right? Kind of how that affects the other siblings in the family. And so I want to say it's just so important. Today, she's going to give more background on her role and present about coping in the hospital setting. So thank you so much, Trisha. Pop on whenever you're ready. I can hear you.
Okay, great. Fantastic. Thank you so much for the introduction. So my name is Trisha. I am
Sorry, I'm going to interrupt. Is your video on, Trisha?
Oh, hold on. Bear with me.
Yeah, no problem. I know.
I have my technical support person named my husband here with me.
Oh, perfect. Down on the bottom
There we
left,
go.
you should
Got
see a
it.
stop or start.
Oh, it says it cannot start the video. Well,
Oh no, I've got you as a co-host. I should be able to. Do you have slides? You're welcome to speak
I do.
and use your slides. All right, let's just go for it then.
Okay. I apologize.
No worries.
I even got dressed and ready. So bear with me. Okay, can you see my slides?
Nope. Are you sharing your screen?
I am.
All right, let me pull up your slides for you. Oh, I see you.
You see me?
I see you.
Okay.
Now if you share your screen, maybe it'll work. Oh, your screen sharing.
Fantastic. Okay.
We're in. All right.
Okay, thank you. Thank you for your patience. I appreciate it. So as introduced, my name is Trisha. I am a child life specialist that has recently been added to the CF team, and I'm very, very, very thankful for this opportunity. I'm going to spend a little bit of time chatting about who we are as child life specialists, and then dive into coping plans. So what is a child life specialist? So certified child life specialists, we are certified through a program administered through the Child Life Council. We're experts in child development, and we help patients cope in the healthcare experience we do that in a variety of different ways with play, preparation, education, self-expression activities. We also provide that emotional support and encourage healthy development of children facing a range of challenging experiences related to healthcare and hospitalizations. So what can a child life specialist do for you and your family? Specifically, kind of within the CF world, we can help explain CF in words that your child or teen can understand. And we do that in a variety of different modalities through therapeutic play, medical play. We can create a coping plan to use during some of those procedures, during throat swabs, blood draws. Also support in sustaining that daily home care if that ends up becoming a challenge. We can offer support before, during, and after medical procedures. Provide ways to help your child or teen express feelings and maintain that sense of control, and also help your child explain their diagnosis to others. So, we have a variety of different ways that we can do that. I have everything from little books that can be shared at the preschool level. If you're wanting to share that with a preschool class all the way up through teens. And then also, as mentioned, providing that very, very important sibling education and support as well. So when can you ask for a child life specialist? Well, really, we'd like to say you can ask for us anytime. We're always able and willing to come in and provide that support. But specifically, if you ever notice that your child or teen needs help understanding CF, the reasons for medications, the reasons for some of these procedures that we do, throat swabs, blood draws, and other home therapies. Another time to kind of seek us out is if you're noticing that they're having a difficult time coping with CF or talking to others about it, or if there's going to be a new medical procedure that we're asking them to do that may be challenging for them, or just in general, if they need help expressing their feelings. So now that I've kind of explained a bit about child life specialist. I'm going to talk now, I'm going to dive into coping. So I'm going to start with kind of talking about the importance of coping skills, but then also move on and talk about ways that I see coping being presented, and then finish up kind of with the overall idea around coping plans. So the importance of coping. With coping skills, children can learn to manage difficult emotions and really gain that resilience. This is going to serve them well as they continue to grow and potentially face more difficult challenges. So coping skills basically make small and larger changes easier. So to cope successfully really helps manage a difficult or challenging situation and a set of events. So there's a whole slew of things that come into the way a child copes, but it really can be impacted by age, past medical experiences, family support, the kiddo's understanding of diagnosis and hospitalization, their level of development, and then additional stressors. I mean, you add in COVID and everything else, and that all impacts how kids can effectively cope. So oftentimes when I'm brought in to ask to support, hey, I've got a kiddo who's struggling with, a lot of times a referral will come in from an MD or a parent themselves. Hey, I've got a little one or a teenager who's struggling to cope with these blood draws or home therapies or this, that, and the other thing. The first thing that I really like to do is to chat with you as parents. You guys really are your kid's best resource. So, oftentimes that can come in the form of doing a phone call, stepping outside of a room and talking to a parent privately. But I need to know, tell me about your child. How does your child communicate best? How does she demonstrate pain? What about anxiety? What's helped to make procedures easier in the past? What helps calm him or her? And how can I best support you and your child within the hospital setting? So coping behaviors, there's a variety of different expressions that we see, and it all actually relates to a child's and a teenager's coping. So sometimes we can see coping come out with anger and aggression. Sometimes frustrations can be directed at family members and others unexpectedly. And really that's when a child or a teen feels like they have no control over a situation. Other times we see it with crying, which is a very natural emotional release. Sometimes we see it with denial, disbelief, kind of shock that it's even happening. We'll see kiddos sometimes want to escape. They want to focus on a specific activity to avoid a stressful situation, or they pretend that the condition doesn't even exist. I see kiddos seeking out information, asking to know more about a situation in order to process and understand what it is that's going on. And as Dr. Frieda mentioned, play, right? A lot of times we see things come out in play. So reenacting real life situations. Play can be used as a release and a distraction. It allows kids to talk about their feelings, that sort of thing. Sometimes we see rebellion, really, again, reasserting that independence in order to gain some control. We'll sometimes also see regression, so returning to old routines or behaviors. This can come out sometimes with toddlers. If I have a parent that says, gosh, my 3-year-old has been potty trained for a year, but now we're having accidents and things like that again. So sometimes, that regression of behavior. Selective silence, choosing not to talk, is actually a coping expression, as well as submission, becoming passive or withdrawn. So now I'm going to talk about, we kind of bucket coping styles into 3 different styles. The first one I'm going to talk about, and this is when I'm talking about coping styles, it's when I'm working with a patient through a procedure, through a blood draw, through a throat swab, talking about taking our meds, home therapies, that sort of thing. There are basically 3 different styles that we child life specialists kind of look for. The first one is what we call a watcher or information seeker. These are kiddos who do best when they're able to watch and learn. So if I'm working with a kid and I know that they're a kiddo that enjoys or needs that information, when I'm taking them into the lab, I'm going to make sure that they are in a position that allows that visibility, where they can watch the phlebotomist, they can see what everything is going on in the room. With those patients, I tend to say aloud, step by step, what they are or will be doing. Also describing what they may see, what they may feel or smell. These are all helpful things for kiddos that with a coping style of being a watcher or an information seeker, and also include the patient in that participation. So include them by having them hold or maybe place the Band-Aid or counting during the procedure. The second style is what we call our avoider or distractor. So these patients do best when they look away and focus on something else. So when I'm working with a patient that kind of has this coping style, I'll give minimal information. As I walk into a room, if we're going to be placing an IV or doing a blood draw, I'm going to cover the supplies. I'm going to really try to encourage distraction. So for a younger child, that could be with toys or bubbles or books or songs. For an older kiddo, it could be videos or an iPad, maybe listening to music or having a conversation. Another kind of a neat thing to think about or to consider is asking your child to imagine being another place or a time. What do they see? How do they feel? What do they smell? Recently at Seattle Children's, we've started to add in VR to our lab. And this, for a kiddo who is an avoider or a distractor, is a beautiful thing. They can actually put on a VR headset and totally immerse themselves in another world, which for some kids, that is just exactly what they need to help them cope through what could be a difficult procedure. And the last coping style is what we call a combination style. So these are kiddos who tend to cope by doing a combo of both. They sometimes like to watch and know what's going on, and then other times they look away. When I'm working with a patient that has this type of a style, I'm continuing to assess the information that I'm giving them in that moment. So if it's, for instance, for a blood draw, I will prepare this patient all the way up until the poke. And then when I know that it's time for the poke, I'm going to encourage them to look away. I'm going to work with them in making a plan that includes both watching and then also looking away by offering some form of distraction. Speaking of distraction, here's just a brief list of a variety of different distraction tools that we tend to use. And we try to bucket them based on age, but for infants, we've got, we call oral stimulation. So that could be sucking on a pacifier. We have something called Sweeties at Children's, which is like a sweet solution that we can actually put on the pacifier. That tends to help calm. Obviously, human face and soft voice, music, bubbles, picture books, and that blends into kind of the toddler years of doing more interactive toys, picture books. Blowing bubbles is always a huge thing for toddlers. With COVID, we've become very well versed in using what we call our bubble wands, so to speak. So we don't actually have to blow the bubbles. Light wands, singing. And then once we get into that kind of preschool and school age children, that's when we're really going to start to think about utilizing our deep breathing. And again, we can do that with blowing bubbles. Also video games, iPads, books, movies, counting, singing. And then for teens, again, really focusing in on kind of that deep breathing, conversation, maybe showing, oftentimes with teens, I'll have them show me what they have on their phone, show me some recent pictures that you've taken, talk to me about that sort of thing. Okay, so when we are asked to assist a patient and a family with coping, we always start with preparation. So we have a ton of resources at our fingertips. So part of this preparation, if we have enough time, we have things like prep books. We have a blood draw prep book. We have an IV prep book. Pretty much anywhere that a patient is going to go throughout the hospital, if they need to have x-rays, or they need to have an MRI, or they need to have a surgery, or they're going to be inpatient. We have prep books for a variety of those different areas. So preparation in our line of work is a really important piece, because it really does help with coping. In the moment when I'm with a patient, I will, if I have time, I will, especially for the younger ones, I'll often use a doll or a teddy bear to kind of help explain the steps of the procedure. That way the patient can watch me do it on that stuffed animal or doll. Even they can help with that, so they can kind of wrap their heads around what it is that we're going to be doing. It's important in that moment to let them know what they're going to hear, see, smell, and feel, and also how long it's going to take. So when I'm working with the kiddo in the moment, you might hear me say, you're going to hear the J-tip numbing spray. It sounds like a soda pop can. Or you'll see the nurse looking for your blue lines with their eyes and fingers, or you're going to smell the alcohol wipe that cleans your skin. And then I often like to tell kids what it may feel like. So some kids say the J-tip feels like a rubber band flick. Others say it's cold and wet. And then also giving some clues and indication for how long it will take. So this will take as long as your favorite cartoon from start to finish, but the poke will only be a few seconds. Another thing that we really focus in on is the language that we use. So we really try to use soft, honest language. So when I'm talking about soft and honest language, it's first we're going to start with a tight arm hug. The nurse is going to look with her eyes and fingers to find the very best spot. Next will be the cold, wet wash. And when kids ask me, what does the poke feel like? I'll say some kids say that it feels like a sting or a pinch. Always trying to be honest that yes, they will feel something, and this is what some kids tell me that it feels like. And giving them a job. Your job is to keep your body super still, snuggle mom and dad, take good deep breaths, and then giving them what they can do during it. So you can listen to music, you can watch a show, play a game. Something else that most pediatric hospitals really do try to utilize is numbing cream. So Seattle Children's, we always like to offer numbing cream for painful procedures. It does work. It does help and reduce the pain of those pokes, which then in turn can help your child cope through that, because if we can take away an element of the part that hurts, we then can get in there and we can hopefully start to assist with effective coping. So that numbing cream, it's a topical lidocaine cream. It reduces the pain by numbing the skin before the poke. We have it on site at Children's. It's either LMX4 or EMLA cream. It really should be used anytime that we're going to be considering doing a poke, whether that be an IV, a blood draw, or a port line access. For best relief, we like to place it on the skin at least 20 to 40 minutes before the needle poke. Okay, and one of the most important things with coping is really to give these patients and your kiddos a sense of control. So when possible, give choices, allow them to choose. Do they want to sit on a parent lap? Do they want you to stand next to them? Choose what distraction they might want to engage in. Allow them to choose the type of Band-Aid or tape, and also assigning jobs. So I am very clear about what each person's job is in that room. So the patient's job, your job is to keep your body still, snuggle mom and dad, take good deep breaths. The parent job, my mommy's job, is to hold you on her lap, hold your hand, sing to you, snuggle you. And then the nurse's job is to complete the throat swab or the blood draw. And oftentimes when I'm in those situations when I'm in that room, I will also let them know what my job is. So my job as your child life specialist is to explain to you step by step and to make sure that you're feeling, okay about this in this moment. And then offer distraction. Again, with distraction, offer those choices. You can listen to music, you can watch a show, you can play a game, you can use the squeeze ball, you can talk, you can close your eyes, whatever it is, but giving the patient a choice in what they can do in that moment. And then allow them a choice in their coping style. I will always ask a patient, do you want to know step by step? Or do you want to look away? Do you want the nurse to count 1, 2, 3 prior to the poke or the swab? Or do you want to do a combo? Do you want to know kind of all the steps involved all the way up to the poke? And then maybe do you want to look away? But allowing your kiddo that choice and how they want to cope in that moment is a really important thing. Okay, so now that we've talked about, what coping is, styles of coping, that sort of thing, now I'm going to talk to you, spend my last few minutes talking about what coping plans are. So coping plans basically can help a child feel more in control when they're experiencing anxiety. Coping plans are something that ideally, every kiddo would have a coping plan, right? Every kiddo would be able to come into the hospital and know what works best for them when we're asking them to do a blood draw or a throat swab or any other medical procedure. We encourage children to write the plans themselves, but if they're too little, parents can work with them and write them for them. And basically within the coping plan, we want to include strategies that are going to help the child cope at their best, and then we're going to share it with staff so that way staff knows what they can do to help the patient through that experience. So for younger kids, coping plans, they include everything from I'd like to sit on mommy and daddy's lap. I'm going to hug the bear in my lap to keep my hands busy. I do or I don't want to watch. And again, I'll hug my bear or doll at the same time. I do or I don't want to hear 1, 2, 3 before something happens. And even with little ones, giving them a job. So my job is just to keep my body still. I'm going to take deep breaths. Oftentimes you'll hear me say, you're going to blow it away. The exhale sometimes is just as important as the inhale. And then giving them a choice. I like a Band-Aid and I want one on. As we move into older kids and teens, these coping plans can become a bit more all-encompassing. So, the teen can let us know, I cope best when I do or I don't say anything. I do or I don't, again, want you to tell me everything about what you're doing. I only want a little warning. So I want to be distracted, but I want you to count 1, 2, 3, or no warning at all, just do it. Or I want to be completely distracted. Please don't tell me anything about what you're doing. And I will tell you, sometimes being in the medical setting, we want to over communicate with kids. And it's important for us to know if there's a kiddo who truly doesn't want to know anything. We need to honor that, and we need to know that that is their effective coping in that moment. Or I want to be able to see everything you're doing and want to be told everything that's happening before it happens. Or kind of that combo style. I only want to watch up to this point, tell me everything up until then, and then I'm going to look away. And when I look away, this is what I'm going to do. And again, give the older kids and teens a job. My job will be to hold my body still while I take deep breaths. And I will often tell older kiddos, it's okay to cry. Sometimes kiddos feel like they need to kind of be tough. It's okay if they cry. As long as they hold their body still, we're going to help them get through it. As I've mentioned before, coping plans, we also like to delegate jobs. So making sure that the patient knows exactly who's in the room and why they're in the room. So sometimes kids actually can cope better in having mom or dad with them. Oftentimes that is the case. Sometimes kiddos actually need a parent to step out. That sometimes helps actually with their coping. Or, my mom, dad's job is to distract me, to remind me to breathe, to hold me, to wait outside the room, giving the patient their job. My job is to hold my body still, take deep breaths. The nurse's job is going to be to count 1, 2, 3, or to just do it. So as I kind of mentioned previously, coping plans really, ideally, we would love to have a plan in place before the patient comes in. So this allows them to plan for what they want to do when they're worried, scared, or hurting. And practice coping techniques when the child is at home, when they're in a safe environment, when they're not worried, when they're not hurting. So that way they can quickly assess their coping at a time when they need it. So oftentimes I'll have kiddos kind of visualize going through a blood draw, and remember, take your good deep breaths. Let's practice doing that, and practice doing that while you're at home. For younger kiddos, I can send home medical play kits, and they can practice on a doll ahead of coming in and needing to do it in real time. That practice and that working through those emotions really helps them when it comes time to needing to access their effective coping in the moment. Okay, so here's an example of kind of like a blood draw coping plan that we have. So you'll see within this coping plan, we even have a message to the phlebotomist up at the top. So, if a kiddo needs to not know anything that's going on, I can check that box that says, please cover the blood draw supplies. So that way the patient doesn't need to see them. This is an easy thing that a patient can easily fill out. It gives them a sense of control. So everything from what we're going to do when they're first waiting. So for waiting time, I'm going to bring my favorite book. I'm going to bring my stuffed animal. When getting ready for the blood draw, what am I going to do? Am I going to sit in the chair by myself? And am I going to sit on mom or dad's lap? Am I a kiddo who wants to watch and learn? I want to know all the steps, or no, I don't. I want to look away. This is what I'm going to do when I am not wanting to watch. And then when it's over, right? Do they want a sense of control? Do they want to pick the Band-Aid? Do they want to pick that co-band that's going to be wrapped around? If so, what color do they want? And then always giving that option of, do you want a sticker? Here are the stickers on the wall. What would you like to pick something out? And again, really highlighting on this blood draw plan what their job is. Their job is to keep their body super still. And then talking about afterwards, how did it go? Maybe what can I do next time? A new idea that might help it go even better. And at the very end of it all, we always like to end on a positive. So what's the fun, rewarding thing that you're going to do afterwards? What is something to look forward to? Oftentimes I'm actually surprised when I'm looking at this, when I'm talking to a kiddo. It's not always that new, bright, shiny toy. Sometimes it's, I want to go to a park with my mom or dad or my sibling. I want to pick dessert for after dinner. I'm going to pick movie night. I'm going to pick the snacks that we're going to have. Sometimes it's really the little things that are the biggest things for these kids. So I love it when they can have something to look forward to. Okay, so I will just end my session by saying, remember, you know your child best. We are child life specialists. We're here to provide support in whatever way you believe is best. We really appreciate being a small part of the big journey, and thank you for allowing us to come in and to help. But really, you guys know your kiddos best, and we will go off of what you believe is best for you and your child. And that's it.
Great. I do see one question here. It says, should we request you to be a part of the appointment when we schedule an appointment, or is the day of okay?
Day of is just fine. So anytime you guys are coming into clinic, I am there for every clinic. So it could be day of. I'm there when the first patient arrives, and I'm there until the last patient is gone. So yeah, you can ask for a child life specialist day of in the moment.
Amazing. What a valuable resource. It seems like such a gift that you give to the kid and to the, I'm a mother. I can imagine having somebody walk through that with my child, like what it would do for me as well. So we're so grateful. Thank you for sharing about that.
Thank you.
Oh, one more. I do see, can you send a digital file of that questionnaire? They do it in Spokane, but they don't think they have that. So do you have a copy of that?
So
Sorry, go on.
No, I absolutely can send it. I don't know, Jillian, would it be better?
Yeah, if you send to me, I can send it out afterwards.
Sounds great. Will do.
Perfect. All right. And then just lots of excellent presentations, and thank you for all you do for your patients. Lots of comments.
Thank you.
All right. And I do see for those on Providence, Alaska, I do have April on now, and she says that you do need to request that early. So just keep that in mind if that's the clinic you go to. All right, we're going to move on. Right now we have Katie Sabring. She is a colleague of mine. She works in policy and advocacy, and she's going to share about our Compass program. And so I'll let you take it away, Katie. You're the expert.
Hello, thank you so much for having me. Let me go ahead and get my presentation. So let's see, sorry. There we go. Okay. Hi, so I am Katie. I'm a case manager with CF Foundation Compass, and I'm here to give just a brief overview on Compass. So Compass is a team of CF patient advocates who provide assistance services to help navigate insurance, financial, legal, or other complex issues. And I'll give some more examples of what could fall in those categories in just a moment. This is our team. We have 14 case managers. 3 of them are bilingual in English and Spanish. Ozzy leads the Compass team, and then we have our 2 operational managers, Aaron Stocks and Hajin Moon. So something to point out that's pretty exciting for our team is recently, back in November, Compass received our official accreditation. AIRS stands for Alliance of Information and Referral Systems. So they are the only source globally that sets standards, accreditation, and certification for community information and referral services. So this is something that we definitely do a lot. We, sort of play the role of connector. So we connect CF patients and families to many different kinds of resources, whether it's financial assistance, food, transportation, scholarships, things like that. So Compass eligibility, our services are available to people with CF, including those pre and post-transplant, their families and caregivers and providers. So Compass is open to anyone. There's no criteria when it comes to insurance, income, going to a specific care center, nothing like that. And it is a free program, and it is completely confidential. Okay, so just a few more, kind of more in depth of some things that we do. So we can conduct side-by-side health insurance plan comparisons. So we can research and compare insurance plan options for those who, if they're losing coverage involuntarily, they start a new job, they become Medicare eligible. Really just anything that, would need them to look at their options, and we can research and compare those for people. We can verify insurance coverage and expanded benefits. So if someone is having coverage issues with drugs or a network issue, really anything, we can try to verify that and see if there's any steps that we can take to try to navigate that, whether that's pointing people to patient assistance programs or other resources that could potentially help with those out-of-pocket costs, or take steps to find out about trying to get a drug covered, requesting a formulary exception or a provider network exception, things like that. So again, troubleshooting insurance coverage and reimbursement issues, connecting you with financial assistance and support programs, get answers to legal questions about laws that protect the rights of people with CF, provide assistance throughout the transplant journey, and share educational tools and resources for navigating life with CF. So we can be reached by phone, email, or we have an online service request form process that is found on cff.org. If you go to support, you'll see Compass, and then there is an online service request form you would fill out, and then a case manager would then contact you. And then if you do decide to call or email, that's great too. We're open Monday through Thursday, 9 a.m. until 7 p.m. Eastern. And then on Friday, 9 a.m. until 3 p.m. Eastern. And then our email address there is compass@cff.org. And that is about it. And if anyone has any questions, I can answer anything. If not, you can always reach out to us and we can see how we can help.
Thanks, Katie. I'm not seeing any questions, but I do want to say, the resource you guys offer is so incredible. Whenever you can't even list, right? What you guys do, because it's so broad. Whenever anyone comes to me with any issue, I'm always just just call Compass. I don't know if they can handle it, but I feel like they can.
Exactly.
And so, yeah, I'd really just say that to anyone on here. If you come across any issue and you are lost, even if it doesn't feel like something that we can directly help with, we might be able to. So I would say just call Compass, right?
Exactly. Yeah. And if there's something that we can't help with directly, we will do our best to try to find a direction or resource that is more equipped to answer, those questions or give that type of assistance. So
amazing. Yeah. Thank you.
Yeah, you're welcome. Thanks for having me. Appreciate it.
Yeah, you have a great one. So I've got about 5 minutes aside from Great Strides, but I'm going to do this very quickly because we want to get to Dr. Weinstock. So really, I'm just going to say that I'm sure you've heard from Priscilla and I 1,000 times already, but we are back in person this year, and we're overjoyed about it, right? The magic of Great Strides has always been seeing everyone who shows up with the same goal and really fighting that same fight. And it's one of the few events where families can come together with their CF fighters and enjoy the afternoon. And we couldn't be more excited to get to see all of you in person this year. So I'm just going to give you a few dates quickly. Great Strides kicks off on May 7th in Gig Harbor, followed by May 15th in Seattle, May 22nd in Tri-Cities, and June 18th in Spokane. And then we're looking to late summer and fall for our Tulalip and Alaska walks. So make sure your team is registered, and we can't wait to see you. All right, we are going to jump over to Dr. Weinstock. He is speaking on gene therapies, new treatments, and ongoing trials. Jared Weinstock is a pediatric pulmonologist at Providence Alaska Medical Center. He earned a bachelor's degree in biochemistry from the University of Scranton and a medical degree from American University of the Caribbean School of Medicine. He completed a pediatrics residency at the K. Hovnanian. Am I close? I hope.
Hovnanian, yeah.
Hovnanian, thank you. I just lost my place. Children's Hospital at Jersey Shore University Medical Center, where he was selected as the 2018 recipient of the Nurse's Choice Physician of the Year Award. After his residency, Dr. Weinstock completed a pediatric pulmonology medicine fellowship at Children's National Hospital in Washington, D.C. His research interests include prematurity and the respiratory epithelium, and his clinical interests are in asthma, cystic fibrosis, ventilator management, neuromuscular disorders, and bronchopulmonary dysplasia, among others. In his leisure time, Dr. Weinstock is an avid traveler and enjoys hiking, biking, and running. Thanks for joining us.
Thank you so much. Yes, it's great to be here. And again, thank you for having me. I'll share my screen here. Okay. So this morning I have a very, I think, interesting discussion that hopefully you can at least take a few things away from it. At some points, it may seem maybe somewhat complex, but just know that we are in a very a great time period when it comes to cystic fibrosis, I think anyway, because there are just so many advancements that I see anyway coming down the pipeline. So what I will be discussing today is really what we have in terms of restoring CFTR function right now. And then we'll get into some of the gene therapies and sort of that kind of a picture that we will hopefully be seeing in terms of treating cystic fibrosis in the future, even within the next few years. So all the information you'll see today and that I'm presenting really does come from the CF Foundation's website. It's a very great source, and I highly recommend anyone check this out, especially when it comes to looking at different types of treatments and maybe what will be coming in the future. So the Path to a Cure, we know, is an initiative that was put out by the CF Foundation, first announced in 2019 with many significant advancements in treatments for cystic fibrosis. In fact, 25 programs have been funded so far to support research, drug development, and next generation therapies that we'll speak on today. Now, as you all know, we do have a number of immunomodulators right now that really over the past couple years have taken off and become very useful in treating certain people, of course, that do qualify for them. You see the list of them here, the brand names, and then these are, of course, the generic names or the chemical name in parentheses. And these are either classified as potentiators or correctors in terms of these immunomodulators. The most recent one, of course, in late 2019 being Trikafta, which has a combination of a potentiator and 2 correctors. And then the ones preceding Trikafta here, starting with Kalydeco, and then some combination immunomodulators with Symdeko and Orkambi are listed there. So I think it's important to understand really the potentiators and correctors in general and how they work. So this picture may look a little complex, but let's just try to simplify it. This is a cell membrane, so the outer part of a cell where the medication in terms of either these potentiators or correctors is trying to do its role at the cell level here, okay? So if we're talking about a potentiator, something like ivacaftor, what this is doing is we have the CFTR protein at the cell membrane here. And we'll talk about this in a little bit more detail in terms of what this actually does. But what we're trying to do with the potentiator is exactly what the word is saying, potentiate or increase that channel, the open probability of that channel opening at the cell surface to allow for that CFTR protein to be more effective. So that's what a potentiator does. And then on the other hand, we have correctors, okay? So down here within the cell, we have the CFTR protein being made. However, there may be some issues getting that CFTR protein to the surface, or even some issues with the protein folding or being in the correct position. So this is where the correctors come into play. So you can see with the ones that we have on the market right now, especially the ones that have a combined function, you have both correctors and potentiators working at that cell level to hopefully decrease the symptoms that we see associated with cystic fibrosis. Now, with the Path to a Cure, in addition to the immunomodulators, what else has been really being looked into right now? Well, there's this entity called Ferrotyping, which is a specific type of lab test for mutations that may be responsive to immunomodulators, for instance, but unfortunately, some people do not qualify for it before Ferrotyping is done. So what Ferrotyping will do is look at the cells under a microscope, for instance, and do different types of tests to see potentially if these particular immunomodulators are really responsive to mutations that may not qualify for the immunomodulator as we know it right now. So this is generating lots of data right now, and I think this will continue to be very beneficial for patients, especially with rare mutations in the future. In addition to Ferrotyping, we know there's a certain type of mutation called a nonsense mutation, or a stop mutation. So what happens here is, as the protein is trying to be made, that CFTR, in the recipe of the DNA, it comes to a certain position where unfortunately this mutation lies, and the rest of the protein is unfortunately not able to be made, okay? So right now, we do not have many effective treatments at all to help patients with stop mutations. So this is really a different area that's being looked at right now by different companies that are working on potential drugs to hopefully overcome what we see with a lot of these nonsense mutations. And again, the point of some of these drugs will to hopefully be to bypass these early stop signals so that that full protein can be made. And then funding for 3 different approaches that I'm going to spend some great detail in and hopefully not go too much over time for, in terms of gene therapies and gene editing. So what does this involve in terms of gene therapy? Well, we're looking at really to repair that broken CFTR protein or restore the CFTR protein when none exists. And that's something that's called gene editing. The other approach here is to fix or replace the underlying genetic mutation, which again, we'll talk about. And then it sounds maybe quite simple. Okay, well, let's just deliver the gene and everything will be done. But the big problem, and there are many barriers to this right now that are really being looked at, is there a way to deliver these therapies to the appropriate cell types? And things that are being looked at right now are ways to really package these gene therapies into things like fat particles that could really help us deliver the genetic material to the cells. And something like this could really be also significant for other rare diseases, not even rare diseases, but other disease processes that we know that may be helped out significantly with gene therapy. So we know that long-term gene editing therapies are very challenging to develop, but even target stem cells are another point of this that we'll be getting to in a bit, really to help us look at a way of delivering a cure to cystic fibrosis. So this is from the Cystic Fibrosis Foundation's website. This is the clinical drug pipeline in terms of restoring CFTR function. So what we see here, the first couple, we can already see these are already on the market to patients. These are our infamous immunomodulators, including Trikafta at the top here, and the ones that we are all familiar with below. And then you can see there are a whole bunch of different therapies that are right now still under clinical trial, including some additional immunomodulators that I think we will see in a very short time, just looking at combining some other potentiators and correctors to see maybe if there is more of a beneficial effect. And then also a handful of therapies looking at what I referred to earlier as that nonsense mutation or that stop mutation. And of course, the gene therapies or gene editing therapies, are a lot of them here on the side are in preclinical trials. But again, just know, you see here, a whole handful of companies are really looking at gene therapies as an approach to hopefully a curative solution to cystic fibrosis. So gene therapy in general, what are we trying to accomplish here? Well, we know the CFTR gene, or the cystic fibrosis transmembrane conductance regulator gene. It's a handful, right, that word. But this is a protein that we are having a problem with in cystic fibrosis. So this particular gene, the CFTR gene, contains instructions for making that protein. So when there's a mutation or an alteration in that protein, that's when the production of this will be affected, and we see the symptoms that correlate with cystic fibrosis. So in cystic fibrosis, we can have mutations that result in no protein, not enough protein, or that protein's made incorrectly. So the gene was first discovered in 1989. And again, like I mentioned earlier, scientists have been trying to find ways to correct the mutations for a number of years since then. And like I mentioned at the beginning here, there have been many breakthroughs just in the last 10 years, which have really helped to accelerate the advances in gene therapy that we're about to talk about. Gene therapy is also known as gene transfer or gene replacement, so you may hear those interchangeably. And gene therapy, to put it hopefully in a simplified definition, is a new correct version of the CFTR gene that would be placed into the cells of a person's body, which would hopefully allow for the presence of that correct copy of the gene so that the cells can function normally without any of the effects we normally see with cystic fibrosis. So what would the benefits be for this? Well, by delivering the correct form of the gene, This could potentially work in any individual with cystic fibrosis. It does not matter what type of mutation is present. Remember, right now, with the immunomodulators we have on the market, there are specific requirements in order for people to qualify for this. So with something like gene therapy, where we're delivering the correct form of this, these kinds of requirements will not be in play. And you may only have to receive the therapy only once or maybe a few times in a person's life. Now, the disadvantages, of course, everything comes with a disadvantage. But by delivering gene therapy to certain cells, this therapy can maybe only work in those cells that receive the therapy. So for instance, of course, lung disease is a big, big part of cystic fibrosis. So if we're delivering the gene therapy to the lung cells, perhaps the cells in the digestive system or the pancreas or other parts affected by cystic fibrosis may not see this benefit. If a person already has significant organ damage or even a degree that's already occurred, gene therapy is not likely to fix that. And it cannot fix any scarring or other permanent damage that has happened prior to receiving this. So of course, there's many challenges with this. And of course, delivering gene therapy technology is a huge, huge hurdle that's being looked at right now in clinical trials. Really, they usually start with animals, but in the very near future, we will probably be seeing some clinical trials to test the safety of this therapy in people with cystic fibrosis very soon. So to put it in a picture form for gene therapy, again, let's try to keep this simple. This box here, just picture this as the cell. And inside the cell, we have what's called a nucleus, where the gene for the CFTR is read and the protein is then made and goes to the surface here of the cell. So what's happening here is in cystic fibrosis, we have a problem typically making this particular protein or a problem with it functioning at the surface. So by coming up with a gene therapy, here's the gene, let's say this is the correct form of the CFTR. We find a way to package this in something like one of those fat particles, like I mentioned earlier. And then essentially it's delivered into the cell, and this new gene finds its way into the nucleus, whereby the correct recipe for the protein is made. That's putting it simply. Of course, it seems like, oh, well, maybe, that shouldn't be that hard to develop, but of course it is. And it takes into account all of those challenges that I mentioned earlier. Now, how about something like non-integrating gene therapy? So let's look at this. So imagine we have a piece of DNA with a correct copy of the CFTR gene that we give to the person's cells, but the DNA remains separate from a person's genetic code. So the best way to put it, and this came from the CF Foundation's website, it's like placing a new page between covers of an existing book without permanently attaching it. Remember, the therapy I just talked about would be a permanent fix potentially, but this one would remain separate from the genome. But again, the cell can use that new copy of the CFTR gene to make normal CFTR protein. The advantage here of a non-integrating gene therapy would be that we're not disrupting the rest of the genome, okay? Whereas beforehand, when we're delivering what I just talked about, the gene, this is it being incorporated into somebody's genetic code, perhaps, and there could always be side effects with that that are still hard to foresee. So with this kind of a non-integrating approach, there's a lower side effect risk, but the disadvantage here is that it's not permanent. So the effect of the gene might last only several weeks or months and may need to be treated repeatedly for this to be effective. Now, RNA therapy, this one has been a little bit more advanced in terms of clinical trials, and we'll get to the details on probably the next slide or two. So what is RNA? Well, we have to understand that. So we talked about genes being composed of a series of DNA letters, okay? So the DNA is essentially the ultimate recipe, and it gives the instructions to make a protein like CFTR. But the cell, this is very important to remember, the cell does not use DNA directly. What happens is DNA, that ultimate recipe, is turned into RNA, okay? And then the RNA is what is used to build the CFTR protein. So imagine we come up with a therapy using RNA, we're really bypassing the step of DNA needing to be turned into RNA, okay? So with this approach, the cell would receive the RNA copies directly instead of the DNA copies. Again, the big advantage here is we're not disrupting a person's genetic code, okay? But the disadvantage, of course, is that, again, it may only last for a short time, maybe 1 or 2 weeks, and you would need repeat doses to see improvements. Again, this is all being looked at in more detail. So putting it in comparison to something like a DNA therapy versus RNA therapy. So up here, this is another way of packaging genetic therapy potentially in a type of virus, adenovirus, okay? So what's happened here is the DNA is placed into this virus, it goes into the cell, gets into the nucleus where the recipe is read, and ultimately that protein right here, the CFTR, is made correctly and hopefully functions correctly. The RNA therapy, which I just talked about, here we're delivering it, but look, it goes right up to this stage. It bypasses needing to make the RNA over here, and we're already delivering that RNA so that it could then be made into the protein which is CFTR in this case. So just a visual way to look at it. And the big difference here, remember, with RNA therapy is that we're bypassing certain steps. So this is a trial that's ongoing right now with humans, okay, looking at RNA therapy. It's called Restore CF. It's in very early phases, but it is taking place at multiple care centers across the United States. And what they're looking at right now is the safety and tolerability of different doses in adults with cystic fibrosis. So the way they're delivering this medication is through nebulized treatment, just like you would do any kind of other maybe breathing treatment, like an albuterol treatment or pulmozyme treatment, okay? So right now it's a placebo-controlled study, meaning some people are receiving the drug, which is known as MRT 5005, just because it's in a clinical trial right now. This is how they have it labeled. And of course, others receive a placebo. And then they compare the difference as these people are receiving the therapies in terms of how much drug gets into the body. And then over time, these people are followed for at least 12 months after the last dose of the study drug to see really what is going on after the treatment has stopped. Is this going to need to be repeated? Are there any issues with it? So this is what's going on right now with this particular study. Now, the requirements for these people right now, and again, this is just based on the company study requirements and research that has gone into this particular therapy, but the people that are included either have a class 1 or class 2 CFTR gene mutation, and they may be receiving or can be Orsimdeco. Okay, these are the requirements for this particular study. So it'll be very interesting to see, and I think we will see some more results for this, of course, over time, once this continues to progress. But very, very nice to see that something like an RNA therapy or genetic therapy is already making its way into human clinical trials. Now, gene editing. This is a different kind of approach, but again, we are dealing with the genes for cystic fibrosis. So the way this works is in our bodies, we have machinery, exactly what it is functioning as, to repair any mistake that may occur as our cells are reproducing. Remember, our cells are constantly dividing and producing more and more and more. But every now and then, it's not perfect, the mechanism, so there may be some mutations, and the hope is that our bodies can repair these mutations before any damage is done long-term. So with gene editing in cystic fibrosis, what we need to do is, and what the scientists have developed, are essentially tools that get inside a person's cells, which can be very challenging, as I wrote here. But essentially what happens here is the tools go into the person's DNA and find that area where the CFTR protein or the CFTR gene, where there's a problem with that gene, where the mutation lies. And what the gene editing tool will then do is hopefully snip out that certain area and essentially allow our bodies to repair what is done to that gene using a template or a recipe that we give to the cell, okay? So there are a few different tools that scientists are looking at for this. The most popular one is called Crispr. You may have heard this. It's been used in some other disease processes as well. It's actually very inexpensive compared to some other methods, but it's also very easy to customize according to the scientists. So what happens here is that the CRISPR gene editing tools involve a guide, like I mentioned, that locates that mutated sequence in the CFTR gene. There's also a template included with the correct recipe to make the CFTR gene or the CFTR protein. and then scissors that will then break the person's DNA at the site of the mutation so that the correct part can then be placed in, okay? So that's exactly what it says here. Once the tools enter the cell and reach the mutated DNA, the scissors snip out the mutation, and then hopefully this repair machinery will then permanently correct the mutation in the cell. This looks more complicated than it really is, but again, what's going on here is the gene editing tools snip out the DNA right here where there's a problem, and then the templates are up here, and using the tools that are provided within the body and through these gene editing tools, the template is then added into this target DNA to essentially allow for correct production of the CFTR protein. And this is along the same lines, but just a different type of CRISPR technology. So what are the benefits here? Well, the changes would be permanent because you are snipping out the wrong piece, putting in a correct piece, and this would really require hopefully one treatment with a gene editing tool and would have a lasting effect on the disease. Of course, the disadvantages are that there are many, many cystic fibrosis causing mutations. So sometimes the gene editing tools break DNA in the wrong place in the genome versus where we really would want this to occur in somebody with a particular mutation. So of course, this is a very, very precise tool that would need to be formed, and really, you know, it would need to cover a whole wealth of different mutations, and this could be certainly a challenge, of course. So it's a very active research area. We are nearing some clinical trials for this and even treating some diseases of the blood. But for cystic fibrosis, it's currently being tested in cells in animals right now. And of course, will be a number of years before it can be safely tested in people. And finally, I know I'm probably coming close to the end of my time here, and this is a lot of information, but stem cells. I would be remiss if I did not mention stem cells for cystic fibrosis therapy. Stem cells, the way to think about this is these are a type of cell that can really produce any kind of a target cell in the body. So they're I don't want to call them baby cells, but they're very original, let's say, okay? And they can be designated to form blood cells or lung cells, things like that. And you may have heard of stem cells being used in the past for other treatments. But for cystic fibrosis in general, scientists are actually looking at how adult stem cells could be used to treat CF. So airway stem cells, these are found in the body. The stem cells in the airway can produce other types of cells in the lung to then replace those cells that are dying or are damaged, okay? So imagine using the gene editing that I just mentioned, or even the gene therapy replacement methods. If we can deliver these to stem cells, then every cell produced from the stem cell would then have that correct gene. Okay, so that's what a stem cell would be used for in terms of this kind of a therapy. So if an airway stem cell had a correct copy of CFTR, then the new lung cells that would be produced would also have the correct copy. And these effects would hopefully be long lasting, okay? But the challenge here is we need to learn how to identify the airway stem cells and where to find them in the lung so that they can be delivered effectively. Just again, to emphasize what a stem cell is. Again, it's an original type of cell that could then go on to produce a number of different types of cells. But again, if you provide the correct recipe for CFTR to a stem cell in the airway, the hope is that all the cells that it then produces will have that correct recipe so that the correct protein is made. My last slide. How do we get these therapies to the lungs? This is a very, very, very hard process with these kinds of therapies. The biggest things to focus on are right here. With cystic fibrosis, the big problem is increased mucus production, okay? That mucus is really trapping anything that's inhaled into the lungs. So if we have a therapy that we're trying to inhale and get into the lungs, the mucus could certainly make it more difficult to get to the cells. So in the lungs of people with CF, remember, we all have mucus, but in people with cystic fibrosis, that mucus is much thicker. So potentially these newer therapies could have a harder time reaching the level, the cells that we really want them to reach because of that mucus. And then of course, that cell membrane, that outer part of the cell, we need to figure out how to get these therapies past that cell membrane and into the cell so that that protein can be made very effectively. Last picture slide here, really just in putting it all together here. So remember, the genetic therapies that they're looking at right now, either involve DNA being packaged into something like a lipid or fat particle, or even a virus, which would then deliver this to the cell and allow for that CFTR protein to be made. And essentially, hopefully the symptoms of cystic fibrosis would never occur or would decrease significantly, okay? So again, just looking at this one last time, just know that all of these on the side here are really involved with a lot of the genetic therapies. This is the one I just mentioned down here, MRT 5005 is that mRNA therapy, which they're looking at as a nebulized treatment to the lung. But just know there's a lot of good stuff going on right now. So finally, remember, there's been so much progress just over the last few years. We know the CF Foundation is the world's leader in the search for a cure for CF. We have many research projects that are ongoing right now to tackle this disease. The journey is not an easy one. There, of course, will be many paths and unique challenges, as we've already seen. But remember, someday CF will hopefully stand for cure found. And with that, I will take any questions or comments. And sorry if I did go over a little bit.
Oh my gosh, no, you were perfect, right on. I am not seeing any questions, but I am seeing some stuff in the chat, and I think I'd like to just echo it that, you take all this very scientific information and you're explaining it in such a way that makes it feel very approachable. And so it's just so appreciated.
Thank you. Yes, it is. It's a complex area. I really just, even if you could take away something from it, just know, I think the important thing is that we've come a long way. And I think within this short amount of time, we'll be seeing a lot of this happen. And I think it's important for anybody with cystic fibrosis and families to understand what they may potentially be receiving in the future. Any medication you take, you should hopefully understand the purpose of it and how it's working.
Definitely. So exciting. Thank you so much for your time.
Sure, absolutely.
All right, now we are going to have Dr. Goss joining us with a research update. Dr. Goss is a professor of medicine and pediatrics at the University of Washington. He is the co-executive director of the CF Therapeutics Development Network Coordinating Center, housed at Seattle Children's Research Institute and Seattle Children's Hospital. He has been intimately involved in CF clinical trials since 1999, including work that addressed the role of azithromycin use in CF, inhaled tobramycin in CF, and the impact of CFTR modulators on patients with CF. He is an epidemiologist and is the co-chair of the CF Foundation's Patient Registry Committee. He is also the associate director of the Adult CF Clinic at the University of Washington with over 20 years of experience in clinical CF. And I know we all think of him as our all-star. So we're so excited to have you, Dr. Goss.
Great, thank you. And Julian, I hope you can hear me.
Yep, you sound great.
It's great to talk to you guys all again. I'll grab my slides just a moment. That was a great talk. Really enjoyed that talk, and I think it's really important when we're thinking of this new era, which is going to be gene therapy, that we understand it actually in a fairly deep way. And I'll just glance on that topic because I think it is really important. But I just want to remind everyone that get that back. Just remind everyone that the CF Foundation has done an amazing job, sort of really establishing sort of unified care in CF centers. So there are over 120 accredited centers. And since 2014, it's increased the funding, the CF Foundation, for the funding for our care centers by 120%. So what CF patients see on the ground is this wonderful integrated multidisciplinary care that comes at a cost that actually is supplied to the centers to support that. Today, we continue to evolve our care model and try to meet the emergent needs of patients with CF, and they are clearly living longer and hopefully a lot longer to come. They also invest heavily in research, as you've seen by the prior talk. This is just to outline the United States, where all the CF Therapeutics Development Network centers are in the country, including Anchorage. So you can see that all of the country are centers to conduct clinical trials throughout the United States, and ensure that actually novel therapies and like gene therapy can actually be done in a rare disease. Other rare diseases are trying to mirror this network system. The coordinating centers in Seattle, and that's what I co-direct with Dr. Mayor Hamlet. But what's been happening in CF, and I think Trikafta or ETI is another term that's been used, or which stands for elexacaftor, tezacaftor, and ivacaftor, has really had amazing and dramatic reductions in exacerbations and hospitalizations in the United States for CF patients, and really a dramatic reduction in the number of patients needing lung transplant, and a really rapid uptake of the drug in the CF community, and it's likely changing microbiology. And again, it's now approved for children 6 to 11, and obviously under study in younger children. So we don't know if this drug will actually reshape how children's lungs develop and whether they actually prevent any sort of the long-standing injury that actually CF causes in the lungs. The other key thing is drug development continues to be really important for the CF Foundation. CF Foundation, as noted before, it really is a leader in philanthropic drug development. And there are over 40 therapies in drug development with the potential to improve the lives of patients with CF. And they're investing more than $225 million a year in CF research and care. In 2020, during the pandemic, more money was spent in CF research than ever, which is astounding. So we really didn't miss a beat, even though the pandemic swept over centers throughout the United States. I did want to give you just a little heads up of how Trikafta has affected patients, and this is the number of exacerbations in the registry reported on a monthly basis. In the red dotted line above is adults. So on average, there were, before Trikafta and before the pandemic, there were about 1,400 to 1,800 exacerbations per month. And these are requiring IV antibiotics. And the blue line, the pediatric patients, these are, the red line is 12 and older, and the blue line is under 12, 11 and younger. And what you see is that once the Trikafta was approved, which is really the end of October of 2019, exacerbation frequency just started to fall dramatically. And then the pandemic hit, and patients isolated themselves and stayed away from respiratory viruses, and it continued to stay very low. We don't know what's going to happen as societies opened up after the pandemic, but we're watching it closely. And this is a graph which comes from the International Society of Heart-Lung Transplant. It notes the number of transplants in the United States, the total number, and then the number for CF. And had been very steady, the number of patients with severe disease who required a transplant. It's roughly been around 11 to 15% of the total number of transplants. But recently, it really has plummeted. And so much so that there were only 43 transplants last year in 2021 for patients with cystic fibrosis, when prior to that time, we've been averaging 250 to 300 a year. And that has a lot to do with Trikafta. So a lot of our patients have actually come off transplant lists, which is, I would never have thought possible. It's been so stark and so dramatic that most of us could never have anticipated this kind of change. And again, we're continuing to watch what happens, but it's actually one of the more fundamental sort of, I would say, sort of a signal of what Trikafta is doing doing in the community. But I did want to give you an update on CFF-funded therapeutic development network studies. These are studies that happen within the network because the research portfolio is very, very, very extensive. But first, I want to sort of give you some of these, an idea of some of the very large studies that are not therapies, but help us understand how these therapies are impacting CF patients. So the first is a study we call Simplify, and this is about to close. It will be done, I think, at the end of May. It's a large randomized controlled trial where we see if you can take away hypertonic saline and pulmozyme in patients who are on Trikafta. And it's again enrolling. We'll probably have results in the early fall to say, is it safe to stop these drugs? How is their lung function of patients who've been on them for a long time? How does it affect it once they're on Trikafta? The next large study is called Check-SC. This is a large observational study to see how sweat chloride is changing in CF patients around the country. It's sort of like one of the fundamental studies that have been done in heart disease that we call the Framingham study. And this study will tell us our main indicator of how well CFTR modulators work. So I call it, how is it actually functioning in the community? And what we do know from preliminary looks at this data is a lot of people have had their sweat chloride enter the non-diagnostic range in this very large cohort. Another important study is called the PREDICT and Patients study. And that's an observational study to try to standardize the diagnosis and treatment of non-tuberculous mycobacterium in CF. And that's a bacteria that's really hard to treat. It occurs in CF, and if patients progress to disease, they require often upwards of a year to more of treatment with multiple antibiotics. And this study is going to standardize how we approach all those patients. The last study on this page is called RARE, which is, I think this is a really fascinating study. It's been going on for quite a while. And so for patients who have rare or ultra rare mutations to cause their CF, we refer them to specific centers around the country. From the University of Washington, we refer patients to two places. We've sent them to both Stanford and to the University of Alabama in Birmingham. But there, patients get a detailed assessment of their CF, including sampling of their nose cells and sampling of some of the cells in their gut, if they're willing. And those cells are grown up to try to create model systems to find cures and treatments for ultra rare and rare mutations. There are a number of other really key studies that are just starting up, and one is with Mayflower, and this is a study to understand what happens in women with CF who get pregnant. What we noted is when Trikafta became available, we went from an average of about 150 to 200 pregnancies a year in women with CF to over 600. And it's really important to know, should patients who have CF and get pregnant, should they stop their Trikafta? Are there any implications to the baby? These are all being tracked carefully in this large study called Mayflower. The next study, which adds on to another existing study, is called PROMISE PEDS. And this is a really important study. We studied carefully everyone who was started on Trikafta who were 12 and older in a study we call PROMISE to try to understand what's called the off-target effects of the drug, meaning things like how Trikafta affected the gut, how it affected diabetes, how it affect immune system. And this study will be looking at the same outcomes, but in children 6 to 11, and it's already heavily enrolled. And hopefully we'll get a better understanding of some of the effects, the effects that the main drug companies aren't that interested in studying, but have great implications for patients and their families. Another study which is enrolling right now is called ABATE, and that's an early study to assess the role of IV gallium nitrate to treat non-tuberculous mycobacterium. And this is enrolling in about, I think, 11 or 12 sites around the country. And the last study I want to mention is called BEGIN. And this is a study led by none other than Bonnie Ramsey here at the University of Washington. Bonnie obviously is instrumental in the development of inhaled tobramycin. She actually helped develop the Therapeutics Development Network to Dr. Bob Bell. And this study is to really understand early development in children from birth to 5 years of age in anticipation of Trikafta being available for them, to really understand the implications of starting these drugs in very small children. There are some new and upcoming industry trials, and I'll focus a couple of these. One of the first ones I'll note is AIRDIS, which is a phase 1B and 2A, and this is a study they're evaluating inhaled gallium in healthy adults who grow Pseudomonas. We've already had other IV gallium studies in patients with Pseudomonas infection who have CF that showed real promise, but IV is hard to give. It's associated with some of the toxicity of the drug. So in the inhaled route, it may be very more preferable. So this study is enrolling. We're a site, we'll hopefully be enrolling patients within the next 2 months. Another interesting sort of collection of studies are studies to evaluate the role of bacteriophage. The first company is Armada. There's a phase 1B, 2A study. And a bacteriophage is actually a virus against a bacteria. And we are filled with bacteriophages. We have them in our gut. We have them in our lungs. But these are very specifically curated bacteriophages that attack Pseudomonas. And so what they're trying to do is actually give inhalation of this virus, this bacterial virus, see if it can kill Pseudomonas. Bacteriophages have been used on what's called compassionate use out of Yale for CF patients who were infected with Pseudomonas and other pathogens. It has been used to treat critically ill patients in the ICU who have highly resistant bacteria. So there are a number of, it was first discovered back in the early 1900s and has been in intermittent use since that time. But now these companies are actually trying to secure an FDA pathway to actually a true therapy versus just a compassionate use therapy. Biomics is another company developing bacteriophage. Each of these are slightly different. So these are sort of very novel approaches to chronic lung infections that have really had very little attention in the United States for a long time. I did want to talk about the upcoming and new industry trials. So Vertex has a whole new program. This is VX-121-101, 102, and 121-103. And these are two phase 3 trials to compare what's called VX-121 with that includes and then tezacaftor and deuterated ivacaftor with normal Trikafta. And the key advantage of this new drug is it's once a day. It may have toxicity benefits over Trikafta, and it may be more active against in CF patients. So this study there are two different studies, very much mirrored after the big program that gave us Trikafta, and this is enrolling quickly. I think patients are about to enroll in our center starting in about 2 weeks. And again, now it's not a startup. It is enrolling in many centers across the country. And given the speed of how Vertex has enrolled their prior trial, my guess is this will also be a very rapidly enrolling trial. I did want to just mention gene therapies. I know you had this lovely talk before about gene therapies, but I want to give you the overall structure of how the CF Foundation is looking at gene therapies. So again, the path to cure, $500 million of initial target funding through 2025 to chart a path to the cure. There are 22 active programs funded. And there are 3 big strategies. One is to repair the broken CFTR, and those are CFTR modulators. So we have the current modulators, new Vertex modulators. There's other companies developing demodulators. Restore CFTR function with these RNA targeted therapies. And RNA, as you noted in the prior talk, these are therapies you might have to give multiple times, but can give hopefully potentially sort of intermediate duration correction of CFTR, and then replace or fix the CFTR with DNA targeted therapies. And so for gene restoration, they hope where what technologies are needed. I think gene restoration, you have to improve existing RNA technologies. So you have to be able to redose, redosable approaches to target the lung, improve the duration of time or the time to redosing. For gene delivery, they need to target specific organs, so you can create little molecules on your cargo, on your capsid, viral capsid or lipid that can target very specific cells in the lung. You hopefully can generate a gene delivery system that can be redosed, and then again, the potential for delivering gene therapy systemically all through the body. And then gene editing, how do we insert a functional CFTR and restore CFTR function in all people? Again, you heard a little bit about that technology. It's there, it's evolving. The field of gene therapy has exploded in other diseases. You may have read that sickle cell is on the path to being cured by gene therapy. Their approach is much simpler. They get to take out blood from a patient with sickle cell. They can take stem cells from that blood, and they can out of the body. They can re-engineer the genetics and then reinstill those cells. And they'll go into the bone marrow and start to make cells that do not form sickles. So here are some of the gene therapy programs. We know there's sort of CFTR restoration. So they're mRNAs, or typical oligo or small little chains of nucleotides. There's one in stealth mode, meaning it's not publicly noted. There's another for mRNA. There's Arcturus, which is ongoing. Nonsense mutations, these are sort of mutations that create a stop mutation, so they don't make a full protein. There are a number of companies doing that. And if you look at gene delivery, I think 4D molecular, which is probably the fastest ahead. This is a viral packaged gene delivery, and we will be enrolling in this study probably in the fall. It has already gone through approval within the Therapeutic Development Network. It's marching ahead quickly. Spirovant is another virally delivered gene therapy. And then there are non-viral delivered gene therapies and other. And then gene editing, again, there's a couple companies, Life Edit and Metagenome, and there's also specific biologics. But there are a bunch of tools that we're also developing. And we're developing these. The foundation has supported Loveless, which is a big research institute for developing products, and also Marshall Farms and Biomed Innovations. So again, these are some of the things that are happening. But I think it's noted as the talk that you had before is so apropos to the timing. Again, the first studies are already moving to the clinic. We've had experience with mRNA therapies already, and more are coming. Again, with 4D therapeutics, we're going to have a viral packaged gene therapy that will begin testing in CF patients this year. And again, tremendous, I think, interest in moving forward into gene therapy, but importantly, safely. I think there's been a lot of oversight of these programs to make sure that we do it safely and we do it carefully, but that hopefully we can make that next big advance in CF. So I think the future, what does the future hold? I think Trikafta, I think, is having a major change in CF. And I think we need to build on this breakthrough advance. It's going to take us probably a number of years to really fully understand what Trikafta is really doing to the CF community. What patients, what is it, how does it prevent disease in small children, disease progression? How long will we have? What is the rate of lung function decline or non-decline that patients have who have existing disease? How does it affect other complications of CF like liver disease and diabetes? These are all questions we will be able to answer in the near future. We still need to do more. I think persons still die too young with CF. And there's also, I think, we want to turn this into a disease that is just something someone with CF lives with, but does not track their every aspect of their life. And Trikafta has given us a little bit of that window. I think I have patients in my clinic who really feel for the first time in their life that they don't have CF, which is really remarkable. But we really do have the capacity, I think, to defeat this disease. And I think we're really not done, as noted in the prior talks. 10% of patients also are not eligible for Trikafta. So we can't leave them behind with this major advance. And I think we really need to move for a cure, a one-time cure, where patients can be treated when they're very young, and that's the end of their disease. So I want to thank you for your attention. I certainly have time for questions if there are any.
Great, I see a few. One is that some patients are being told in other clinics that they can drop treatments. Are early Simplify studies showing results showing this is okay, or are they doing this without test results?
That's a good question. We have a study where we're tracking what people are doing, and not necessarily what we're telling. I think patients are self-experimenting, and they're stopping some of their therapies to see how. Our advice in our clinic has been generally to keep doing your regular therapies until we have more evidence. We will have that evidence very shortly. I certainly have experience of one patient who was in a Simplify study and stopped Pulmazime and then is back on it. Noted that lung function didn't change, but symptoms worsened, and also the small airways disease worsened. So I think we'll know soon. It is, I have some cases in my clinic. So hypertonic saline is very irritating to breathe. I've done it myself just for fun. It's very irritating if you don't have CF, and it's irritating to a chunk of patients who have CF. And that, for some patients on Trikafta, seems to have been causing a lot of irritation in their lungs once they were on Trikafta. So I've had a number of people drop hypertonic saline because of the beneficial effects of Trikafta. I think made it actually quite irritating. So it's, again, my advice has generally been to wait until they get those results, but patients are doing sort of what I would term their N of 1 trials. They're stopping some of their therapies and measuring their home spirometry or getting office spirometry and seeing how they feel. But I do think it's an era where a lot of the knowledge we have in what CF was is not the case anymore. We have to go and relearn again what does CF look like in the post-Trikafta world.
Great. And when you're talking about these studies and you say it's in a phase 1B/2A, can you just explain what that means?
Yes. And that's sort of the mystery of there's no law of how you label studies. So phase 1 tends to be first in humans. Phase 1B tends to be, they've done the human trials, healthy volunteer trials, and are moving into a disease setting. That's not always the case, though. And so those are, once you get to phase 2, generally you're trying to establish proof of principle that your drug really does what you say it's supposed to do. And so a lot of companies following Vertex's lead have melded all the different phases. And there are some companies who try to make it almost like one giant phase, and it does healthy volunteers in the beginning, and then it starts marching through different phases, and depending on success, they keep adding on to larger and larger trials. The phase 3 trials are the definitive trials. In the classic FDA application, you need 2 identical, large-scale, randomized controlled trials of your drug and showing effect in both, as to sort of that's been sort of the standard for a long time. As you get smaller and smaller subgroups, those rules all fall apart. And that's because you just can't do 2 large-scale randomized controlled trials in a subset of patients with a very specific mutation. So, but that's what generally it's phase 1, phase 2, phase 3, but you'll see a lot of phase 1A, phase 1B, phase 2A, 2B, 2C, and then, but generally phase 3 is always just phase 3.
Great. So it sounds like phase 1 would be healthy humans. Phase 2 is when you're getting more specifically into the smaller trials.
Phase 1 will be healthy volunteers plus first in your disease setting to test safety alone. Phase 2 will be proof of principle, like you're going to show that your drug does what it's supposed to do and collect more safety data. And phase 3, it says definitively, this works.
I love it. And one last question. Do these studies look into the mental impacts of these meds as well?
They're not. I think it's a really good question, because there's a lot of question going on about what are the effects of Trikafta on people's emotional state and mental state. If you read the blog, I'm not very good at reading blogs or the websites, but I think I have a lot of patients who've noted agitation, anxiety with Trikafta. So there's actually a big study in the planning to try to understand some of the mental health aspects of these medications. I wonder, what that they may. It's always, when the drug is developed for CF, the studies are actually relatively small. It's a small population. So sometimes these effects we see once the drug rolls into the greater population, we really have to keep our basically finger on the pulse and see if something's happening. And so there is a study in the early planning stage to try to understand this. It's a little hard to figure out how to do it, so they're still working on it. But it's hard to. We've done a bunch of dose adjustment in our clinic to try to see if we lower the dose, can the agitation, some of the anxiety that may be happening with Trikafta be modified? It seems to work. So again, that's anecdotal medicine. I don't know if it's true, but I do believe, if it's hard to imagine that so many people now have new anxiety and they didn't really have that bad anxiety before Trikafta and after. It's hard to say that the drug doesn't have this potential as a side effect, but we don't know yet if that's true or not.
Sure.
It's also in the midst of the pandemic, so that caused lots of problems with people's anxiety and their own personal feelings, including mine as a physician. So
amazing. Dr. Goss, you're always such a joy. Thank you so much for joining us today.
Well, thank you for having me, and Again, thank you all for what you do for CF and for hopefully looking for a great strides. And I won't be at the great strides because I am at a meeting in San Francisco, but I hope to be at the bike ride.
Oh yeah,
we have it in person this year.
We've got some good plans for it. We'll
event.
keep you updated in person, definitely.
Well, take care.
Goodbye. All right, we are going to move to Dr. Murphy. Dr. Murphy is a product of the Pacific Northwest. He graduated from Olympia High School and the Evergreen State College, and then from University of Washington School of Medicine in 1982. In 1985, he completed his residency training in pediatrics at the UW Seattle Children's Hospital, back when it was still called Children's Orthopedic Hospital. After working abroad, Dr. Murphy completed his pediatric pulmonary fellowship in 91 and a research fellowship in 92. After a brief stint as faculty at the UW, he moved to the University of Pittsburgh, where he was on faculty for 19 years. During that time, he added fellowship training in pediatric sleep medicine. He moved back to the Northwest in 2011, where he joined the private practice of Pediatrics Northwest and began to provide pulmonary and sleep medicine care at Mary Bridge Children's Hospital. Thanks for coming on, Dr. Murphy.
Thanks for having me. I will try to figure out how to do this.
We'll walk you through it. We can hear and see you great.
Okay, good. The sound is all right?
Mm-hmm.
All right. Well, let me see if I can do my advanced portion of screen share. Does that look like a talk?
It looks amazing.
Good. Well, let me get started then. I've been asked to talk about the newer developments in the pipeline for drugs available to patients. And I was thinking of quickly texting and asking security to remove those other doctors because they were going to ruin my talk by getting everything I was going to talk about. They covered it, but I'll try to do my best anyway. I work at Mary Bridge Children's Hospital. We're the Tacoma affiliate CF Center for the University of Washington CF Center. I wanted to start off with a reminder. For years of talks, I can't believe how many years, actually all of those years, I've been talking about cohorts of CF and how they do in lung function. And what you see in this slide is from age 6 to 30 on this slide. A cohort of patients means a group of patients born in 1991 compared to those born in 2001, compared to both those born in 2011. You can see that each decade, the cohort does better than the one that preceded it. But even so, we see that over those years, the FEV1, the forced expiratory volume in the first second, has shown a decline over time. And that's been there for the last 30 years of talks I've been giving. And for the first time, you can actually see lung functions improving. And that's across the board in every cohort. These are not divided by decades. But you can see that even in the older cohorts, born in 91 to 95, these data are from 2020. There are improvements being seen in all cohorts. And it's just very gratifying and really very moving. So I wanted to remind folks that we're talking about a lot of different steps along the way. And as people have already told you, there's a problem in the CFTR gene that leads to an abnormal CFTR protein. That leads to abnormal ion transport at the cell membrane. That leads to a depletion of cell liquid on the epithelial cell layer in the airway. That leads to delayed mucociliary clearance. And that's what leads to our cycle of mucus obstruction, infection, inflammation, and scarring that can lead to end-stage lung disease. For every step along the way, there are therapies that we've developed that we use. And I will quickly click through all of these because there's a lot of them. Some of these, though, are kind of non-starters. We aren't doing much talk about gene therapy right now. Although we've come full circle and nebulized gene repair is maybe not going to be a big thing, but there are now with CRISPR-Cas9 therapy, maybe an ability to repair the gene. Most of what we'll talk about, and you've already heard, is how we can improve the CFTR. And these concepts are all going to line up as areas for the pipeline. What we don't have here is much on fertility or on nutrition, but that because this is airway disease I'm talking about, but this is all there. So if we look at the pipeline and this drug development, we're really remembering we have basic science research, and there are phases of drug development that take us from the basic science to the bedside. And the preclinical formulation stability tests lead us to phase 1 data collection and clinical trials, where we have an average failure rate of about 25% of studies. That then brings us to phase 2 clinical trials, and that has studies dosing and efficacy, and has a failure rate of almost 40%. So that's almost 65% between those two. In phase 3 clinical trials, we're looking at safety and effectiveness. There are subtle differences between effectiveness and efficacy, but it has a little more to do with real life treatments as measured in a real population, and yet 13% more drop out there. The FDA approval process is then the next step, and that leads to what we call phase 4 clinical trials, which are measured after the fact and look at real life impact of the drug in ways that maybe the initial studies didn't find. But this process from can become a pipeline, and the way that works is we just sort of get rid of all the other stuff and we bring these down to form a course of events from left to right, which we call a pipeline in CF. And if you go back to 2012, you can see that we had on the ordinate on the left, we have the problems treated, which follow that same pathway from gene to lung disease. We have a stage in development, which would be preclinical, phase 1, phase 2, phase 3 are available to patients. And then by categories, you can see where they come out. This is where we were in October of 2012. To keep up with that, you can always find this website. I really recommend checking now and then. The CF Foundation YouTube channel has a wealth of information. For this talk, I turned to both of them for help. And there is a superb lecture given by Yulur who is the adult CF program director at Boston Children's and Mass General at last November's NACFC conference. That and many other talks can be found on the channel. So if you review the pipeline, there is you can scroll down and you can see all the different categories. And currently they are, mucociliary clearance would be an example. You can look at a drug in development, you follow it over to see where it is, and that's in phase 2 delivery. And on the far right, you see the ones that are available to patients. In this case, DNase, hypertonic saline, and inhaled mannitol. So you can really find out pretty easily what's available, but what's almost available. So the pipeline categories right now no longer have categories like lung transplant, because as he really pointed out, it was for a long time a static field because there were not a whole lot more lungs coming available. And now it's decreasing in need because of better lung function outcomes over time because of the modulators. What they do have are categories still are restore CFTR function, and what used to be gene therapy is now deleted, and part of that mucociliary clearance, anti-inflammatory, anti-infective, and nutritional GI categories. If we look at that, you've seen this already, so I won't dilly-dally. There's better CFTR function, there's mucociliary clearance, anti-inflammatory and anti-infective, and nutritional GI. If you look at the pipeline closely, though, you will see that down in the corner is what's called discontinued. And if you click on that, what you see is, instead of this view, you see a view that shows all the medications that were in trial that never made it to the finish line. And that, I think, reminds us that all of the hope that we get here does not always pan out, but the persistence is what really makes a difference, I think. You can see that in every single category. I won't dilly-dally on this too long. I just want to remind folks that there are different types of problems, and that of the 1900 different mutations, they lead to all function through these different mechanisms. There might be problems in one of several steps along the way. This might be called classes of defects. Nonsense mutations may prevent any synthesis at all, which would be like a type 1 class. They might be made, but either degraded immediately or not packaged properly for transportation. Could be made in normal numbers, such as processed and placed in cell membrane, but then it may not open and shut properly. It may work a little bit poorly, or it may work nearly normally, but be present in greatly reduced numbers. So these lead to the different kinds of defects, and the potentiators get more CFTR in the cell membrane. The correctors get more of them in the membranes. The potentiators get them to work better. Well, where do we need to go next? We really are not getting there where we need to be for the roughly 10%, was really close to 12% of patients who are not eligible for CFTR modulators. It isn't fully restored in the majority of patients currently receiving, at least as measured by getting the sweat chloride down to below 30. And there's still room to optimize dosing and delivery to see if we can get better outcomes in those who are getting the modulators. So if we look at where we are in restoring CFTR function, where I'm going to kind of begin, I started by designing a slide to say getting closer to market, but I thought, market principles don't seem to really apply to the cost of pharmaceuticals. It is telling me that the news regarding Kalydeco approval in Canada burst on the scene as on financial pages, and a Google search for Trikafta approval returns the first hit on The Street, a Wall Street publication which claims that gene therapy is a hit that is going to be a money spinner for the company. So there's been a lot of focus on the financial aspect of this when you Google search it, but not as much on its pharmaceutical value to patients. And I frequently wish that that was the other way around. If we do look at what's here, there are 5 medications. What might they do? The AbbVie-222 and AbbVie-3067 modulators are being studied alone and in combination, mostly in Europe. And so I'm not going to tarry too long on those two. The AbbVie-222 is a corrector, and it's in a dose response study with Delta 508 deletion homozygous patients. Remember, that means somebody has 2 copies of Delta 508. Sweat chlorides decreased at the 3 doses studies, biggest at 200 milligram dose. There were no differences in lung function, but that's not usually going to be seen in a very brief dose response study. AbbVie-3067 alone and or in combination with 22, also for that group of patients, was studied for effectiveness alone and in combination. And safety, effectiveness, and FEV1 and sweat chlorides were looked at and are being shown in early results to be better, although FEV1, again, in brief studies, you're not going to see much of a difference. Doesn't really address the 10%, but it may improve the restoration of CFTR over the current medications, especially useful for those not tolerating the current modulators. So AbbVie-222 and AbbVie-3067 may, when they hit the shores here, may prove to be quite useful, but I would expect at least 1 to 2 year delay before it gets to a US market, as the studies are being done in Europe. Elox Pharmaceuticals has got a drug in the pipeline, and it is an aminoglycoside-based antibiotic drug. Toby is an aminoglycoside, gentamicin and tobramycin are aminoglycosides, but we've known for many years that they work as antibiotics by disrupting ribosomal binding to messenger RNA, which you heard discussed in both of the previous presentations as drugs that were working on a messenger RNA and ribosomal function. Well, aminoglycosides bind to bacterial ribosomes a little bit better than they do to human. And so they've been tinkering with that. And this one, based on that, binds to human ribosomes better than it does to the prokaryotic. And so it allows the read through of a faulty genetic sequence. So usually when you have a stop codon, a protein just won't be made. A faulty protein will be made, a very small one, a fragment that won't do anything, in this case, CFTR. If you allow it to keep reading, that's called translational read through of stop codons. And if the signal is ignored, then the cell will go ahead and make the CFTR anyway, though it may not be perfectly well made. It can then be corrected. Problem is, aminoglycosides are really pretty toxic to hearing and kidney function and are not really optimized for reading through the stop codons for CFTR in humans. So the goal of the study was to develop small molecules that work like aminoglycosides without the baggage, work better with fewer ill effects. It does have a very strong affinity for human eukaryotic ribosomes over prokaryotic ribosomes, bacteria, leading to less antibiotic activity, but much better binding to the human ribosomes, and maybe allowing for the promotion of the creation of the CFTR. This on the left shows the effects of ELX02 compared to gentamicin. This is a log value scale. So this is 100-fold better binding to eukaryotic ribosome selectivity. And in this case, more selectivity for mitochondrial ribosome, which is what we need to get the CFTR better. If you look at what it does on the right, it shows, again, normal, you can't really see this slide, I know, but this would be normal translational read through, creates a full-length protein. In nonsense mutations, it gets blocked and you get only a fragment of the protein made. And then after the use of the ELOX, you do get a protein made, which is rescued. And this is called rescue for full-length protein. And this is successfully transcribed. If you look at the nonsense mutations we do have, there are roughly 37% come from the G542X mutation, 17% are from the W1282X mutation, 13% from the R553X mutation, 7% from R1162X mutation, and about 3% from the E60X mutation. 23% are from mutations that represent less than 1% of the whole group. So measure in the laboratory the effect of increasing doses of ELX2 show that for a variety of mutations located along the abscissa, and if you didn't take statistics, this is the one thing you're going to remember from today's talk. Ordinate is the up and down, and abscissa is the horizontal. And when you say the word ordinate, your mouth forms an up and down, and when you say abscissa, your mouth goes horizontal. So now you remember that. Well, there you are. So measuring the show the variety of mutation located on the abscissa, like the W1282X mutation, you see that there was a dose response for higher doses, better area under the curve of this in vitro measure, which was actually measuring swelling in a CFTR rated a lab test. And you can see some nice dose response using the ELX2 in 4 different mutation studies. So that led to dosing studies in humans, and this is given subcutaneously. They completed their data collection by the end of year, but just before they did, in October of 2021, they amended the protocol to add ivacaftor. And so rather than a week of each dose being higher over a 4-week period, they started adding ivacaftor at the 2-week time point or 3-week time point for another 2 weeks to look at the effect on their measures, which were FEV1 and sweat test. And it does make sense that if you're going to make more of a protein that didn't work, that if you could get a potentiator in the cell membrane with this maybe not quite functional CFTR, that you would do better yet. And their data released in November of last year, the exciting news here is that the gentamicin-like drug allows the ribosome to ignore a stop code and make a probably somewhat faulty CFTR, and then the ivacaftor can make it work better. So if you look at 2 days and 6 days, there's an improvement in this swelling response in this in vitro model. And we saw this in the ELX alone is the orange, and the ELX plus ivacaftor is the upper bar, which is blue. On the right side, you can see a similar response for the W1282X mutation. This one here on the left was the G542X homozygous mutation. So in these 2 homozygous nonsense mutations with no apparent response to our current modulators, this one seems to lead in this in vitro model to improve functionality. We're now conducting longer trials over a 4 to 6 week period of treatment in humans, looking at dosing and safety. If we look at ivacaftor and ELX2 given over time in a different model of CFTR function, we can see a dose response curve, but a definite improvement in CFTR function when we add ivacaftor, what would be the equivalent of a 150 milligram dose in this in vitro model. So in summary, ELX02 is a model drug that's an aminoglycoside-like read-through agent. It allows transcription of mRNA and the creation of CFTR instead of the stop codon preventing it entirely. Based on in vitro lab experiments, the ELX02 improves CFTR function. It does not function as an antibiotic because it doesn't bind very well to bacterial ribosomes. ELX2 studies are now ongoing to study the subcutaneous ELX02 on dose response in humans, CFTR volunteers, the effects on different nonsense mutations, both homozygous and those who have Delta F508 and one of the nonsense mutations, and then the effects in those groups of adding ivacaftor, which in the research realm is usually referred to as Vertex 770. One of the other ones on that bar that I showed you on the pipeline is Vertex 121, which might be thought of as maybe a hopefully better modulator. This study has 2 parts. The issues that matter regarding why we're doing this is that it might be considered better, in quotes, if once daily dosing is going to lead to better compliance. But you have to prove that single day dosing can work. Even ivacaftor adherence is variable, and over time, the dosing interval can increase. So patients who take, when we first got Kalydeco on the market, here's our very first miracle drug for a very small 4% of CF patients only, but that phase 4 data collection, that real life data collection of medications that come on the market showed that some patients stop taking it as routinely as they should. So Vertex 121, tezacaftor, and Vertex 561 have been studied alone and in combination for once daily dosing. Vertex 561 is what's called deuterated ivacaftor. So deuteration is a process where you take a hydrogen molecule attached to the drug and you replace it with deuterium, which is a heavier molecular version of hydrogen. So the heavier or deuterated ivacaftor is heavier and slower to be metabolized. And so it gives it a longer half-life and allows for some of the triple combinations to be taken once daily. This triple combination perhaps to be taken once daily. Let me go back one slide. I'm sorry. I want to make sure I don't miss anything. I think I got that all. So there's now phase 2 studies of the triple drug going on. This study it has a 20 milligram dose of VX-121. There was by day 29 a nearly 50-point drop in sweat chloride results and a 9.8% improvement in FEV1. Phase 3 studies are planned to be compared to Trikafta versus once daily doses versus standard dosing for patients with 1 delta F508 and 1 minimal function mutation, and patients with 1 delta F508 and 1 mutation responsive to modulators. So both of these groups are being recruited into this study. This study does not go after nonsense mutations, though it does go after minimal function mutations, and it is instead focused on creating a better modulator that folks will actually take. Although, you know, you're getting that from the guy who can't take a Z-Pak and finish it in 5 days. So our conclusion here would be additional modulators can provide options for those who cannot tolerate or do not respond well to the current modulators. Clinical trials are ongoing to evaluate the efficacy of subcutaneous ELX02, the aminoglycoside, at different doses for different mutations and in combination with ivacaftor. And once daily dosing with the triple drug combinations may lead to better adherence and optimized CF restoration. Wow, that's 3 talks in a row, so maybe that's a lot. So I just wanted to finish by saying that the CF group here in Tacoma were Dr. Larson and Dr. Ricker and me and Dr. Jacobs, posing with some of our nice old patients. We've worked for years with the CF Foundation. These 2 guys, Dr. Redding and Dr. Gibson on the left, are the guys that I worked with. We were it when I was at Seattle Children's, and it is needless to say a lot bigger. And I don't have enough pictures of people like Bonnie Ramsey or Margaret Rosenfeld acting silly to add to the images, but I'm working on it. And I think that will be it for me. Does anyone have any questions?
Amazing. I don't know what you are worried about. That was fascinating. I would say it's really, I think everyone can kind of touch on that gene editing and that CRISPR, but those presentations are so unique and you really brought something and we're grateful for it. I do have a question. How important is a change in the sweat chloride for a modulator?
Well, funny you should ask. Let me go back to screen sharing.
Great.
If I can. How do I do that? There we go. Let me just, I have thought about that. So it's not an easy question or slide to look at, but this is really does come up. So it really doesn't matter how much salt there is in your kid's sweat when you lick them to find out if what you read is true. Although with the increasing adult population, I no longer recommend licking people with CF. It's probably get you slapped. But if you look at these studies, we have multiple studies here, and I want to show you that these, I don't know if my mouse is showing, I don't really have a pointer, but up here at the top of this figure are multiple studies of different, pardon me, correctors and studies that have looked at correcting CFTR. And in these 1, 2, 3, 4, 5, 6, 7, 8, 9 studies, there is variable results in how well they changed the sweat chloride. Over here on the right is 0 change. And in a control group, there's not much change in CF sweat chlorides, and therefore not much change in lung function. But as you move to the left and the numbers go higher, we're actually seeing a more negative number. And some tests showing minus 60 or minus 50 point change in the sweat chloride, but that correlates with improvements of 5 to 10 to 15% almost in the PFTs. So there is actually a correlation between lowering the sweat chloride. So say you had a kid whose sweat chloride was 80 and you got a minus 50 on your sweat chloride, you now have a sweat test result of 30, which we would call normal. And the kids, the groups of patients where we see that, it correlates with a lung function improvement of almost 12% in this study, which in this case was the G551D study 102. But the challenge is that in individuals, you can have a kid whose lung functions go way up and their sweat test barely changes, and vice versa. So we don't use sweat chlorides to predict individual improvement, but we do know that it correlates with population improvements. So that's one thing. And the other question one might ask would be, how good is it to do once a day dosing, and is that really an issue? And I just want to show you, this is an asthma study done on using mometasone. It's a daily inhaled steroid for asthma. You can see that compliance in twice daily dosing compared to once daily dosing. The dark bar is, black bar is once daily, the gray bar is twice daily. This is based on the device counter. This is based on what people tell you they're doing. It's better in both measures, and significantly better when it's once daily. If we look at Trikafta, this is not the easiest slide to read, but on the left hand, you can see that ivacaftor, like a life-altering medication for kids with CF, you get them on it and you see how they do. And we have in these gray bars are self-reported. The 1.0 means 100% compliance. So out of these 12 subjects, 11 or so, subject 6 didn't report. 10 said they were perfect, and subject 10 said, I'm terrible at doing it. On the other hand, the MPR, which stands for medicine possession ratio. So what you do is you see how much medicine they picked up at the drugstore where they got, and you see how often they got it. And we see this all the time, where I will tell little Jimmy tractor wheel to take Pepsid once a day. I prescribe Pepsid, and they come in and say, Doc, I've been taking Pepsid every day for the last 3 months. And then I look and I see they picked up 30 doses 3 months ago and they never got a refill. And so I know that's not true. So when we look at data like that, we can see that sometimes they're picking up more medication, sometimes they're picking up less medication, and that reflects on compliance. The most creepy is where we have electronic monitoring of their use of the drug, which is only done in research studies with people's agreement. And you can see quite a bit of variability in the green bars, showing that people taking ivacaftor, these 12 subjects in after marketing studies, phase 4 studies, showed us that even with like this is the home run drug, I forgot to take it. And they didn't take it as well as they said. The gray bar says, I'm doing perfectly, and the green bar says, no, not so much. On the right, this really wild squiggly curves that I wouldn't even try to explain, but the way they march together is in this not so easy to understand figure that over weeks, which is along we now know means abscissa, we see increasing gaps between dosing. And on the upper part, we see decreasing what's called weekly adherence. And so over a long time, in this case, almost half a year, there was a decline in adherence to the prescription. So I really think there's a lot of evidence that there's value in doing that. I think that if we look at this currently available modulators, there's Kalydeco, Orkambi, Symdeko, and Trikafta, and they are all twice daily. And so hopefully, we'll see better results when we get it once daily. The other last thing I'd say, there was somebody asked a question about, shall we quit taking our medications when we're on a modulator? And A, if you're not actually really secretly taking it, probably not. And B, this shows the macrolide use at different CF centers. This is as prescribed by doctors. And you will see that each gray bar is a different center. So some centers are using it nearly 95% of their patients. And the last flat bottom here, not using it at all. And what I'm trying to point out is that there's enormous variability in prescribing azithromycin across all centers. And one of the goals of the CF Foundation is to get people performing to standards in terms of what we prescribe and getting people taking them. But there is a lot of variation in what people do. So some centers will say, yeah, go ahead and stop that. And other people might be a little more cautious. I think at the UW and Marybridge, we tend to want to make data-driven decisions and wait for the data to be collected in these phase 4 studies, or like the Simplify study, before we make recommendations. So there, now I can stop sharing.
Fascinating. We are so fortunate to have you join us today. Thank you for your time.
It's my pleasure. Thank you.
Yeah. All right. Well, then just one big thank you again to all of our incredible speakers for sharing their time and expertise with us today, and to all of you for joining us. There will be a recording of this webinar. You're just going to have to give me a few days to get it off Zoom, get it onto YouTube, and get a link. So if there's somebody that wasn't able to make it, or you'd like to share, or you'd like to revisit a portion, definitely contact me. And when that's all updated, I will make sure to get you a link out for that. But that's all I've got. So I hope you all have a great weekend, and I can't wait to see you at Great Strides. Bye.